That was better than I could have said it. So really appreciate your involvement, your leadership. And as I said to you before, you're really the pioneer. We're just trying to figure out how to sustain the work that you started. So thank you for joining us. Really appreciate it.
I've been possessed with asthma.
Good. Okay. That's okay. We all need a passion, right?
Yeah.
The question is, how do we expand this out of LA County into Central Valley where there's such a great need?
Yeah, I think after this meeting, we are moving quickly in that strategy. So Neil, you and I need to connect again because we have some
I'm at the point after
mutual.
5 years of trying to do it independently that I would do this for nothing. I would do part of this, be part of this for nothing.
Yeah, and we're hearing the same. We're hearing a lot of people say that this is so important to me personally that I would do this for no payment, and
So,
it just tells me we have the right people in the room, right? but you're also hearing that these health plans say we want to pay you, we want to make this worth your time. It's important to us, and that's the way this is sustained, right? That's the direction we're headed.
I mean, if CRMC would do the negotiating and get them to buy in, that's a key role for you guys we're here. And unfortunately though, in Northern California, and at least in Fresno, the independent pharmacies are not, it's mostly penetrated by chains, unfortunately, that I've seen in my dealings with here.
Well, and the chains are actually joining up as well. So we're slowly but surely getting there. But we will, let's definitely follow up that conversation. I think we have most of the group back now, and we're just about on time. And I'm going to try to keep us on time if we can be, as much as possible. So I'm not going to spend too long, but I just want to recap some of the statements and a lot of consistency what was shared about the previous presentations. I think most comments were overwhelmingly about your patient, Crystal. So thank you for your great work with that patient. And boy, what could she articulate with no script? I mean, that was, somebody had commented that, she's not reading anything here. She's just speaking from the heart. So thank you for
it was like just a one long take. That's it.
Yeah, it's amazing. And I'm glad we were able to capture it. And we're going to leverage it for many different purposes, I'm sure. We heard a lot about how impressed people were with the ability of these community pharmacies to establish very meaningful relationships to support CMM. All of these sites that you heard speaking have great partners, and I mentioned a few times that some already have very nice CPAs either completed or in the works. Also, very important. And even one location, Janice, has been able to negotiate getting EHR access from her pharmacy. So pretty phenomenal in terms of what they've been able to do. Someone else highlighted, many people highlighted, that they could see the value of teams sharing their experiences. We all know there's not just one way to take care of a patient. You may have the same set of conditions, but the circumstances, the challenges, the culture, so many different variables to think about, so many that it helps to talk to other people that are facing the same challenges and share some of their ideas that might work. And that's exactly what we do in our regular meetings in the Cal Right Meds Collaborative. And then last but not least, the overwhelming support from the health plans. Again, I can't say thank you enough. And I think all of you are seeing how it makes a difference when you have a health plan that understands the value of comprehensive medication management, the value of pharmacy, and wants to put that value all together to benefit patients with the greatest of needs. So thank you for that. Now, we are moving on to a section that we call Spotlight on Advancing Community Pharmacy-Based CMM. And we decided to do this because the majority of you on this call that are in community pharmacy are not part of the pilots. And I'm seeing in the chat exactly what I expected. A lot of questions about, I have patients like this. How do I become part of this collaborative? And we want you to be part of the collaborative. Now, our timeline is such that, if and then we can roll this out, it'll happen early 2021. But that doesn't mean that you have to wait until then to prepare yourself for the opportunity. As I said before, part of our process since last learning session was creating a fairly rigorous process for determining which pharmacies can participate. And so what we're going to do here is share some of the tips and thoughts that you might want to consider as you prepare yourself for this type of opportunity. So we'll have a couple of our teams share workflow modification. How do they change what they did to accommodate comprehensive medication management? I'll speak a little bit about collaborative practice agreements. And then we're going to have Adelina Ardelline from Good Neighbor Pharmacy talk about personal branding. Think about this. You need to now become known as a place where you get a very high value clinical service, not just a place where you're providing medications. And what I mean by that is you certainly already are doing things like immunizations and smoking cessation and so on, but we want people to know whether those are patients, providers, that what you're offering is integrated into the healthcare system. That's a part of their whole person care. And that's what Adelina is going to talk about. So I'm going to start by introducing Dr. Adelina and Dr. I'm sorry, you know, Ramesh, I spent a lot of time on this. Ramesh Upadhyayula. Oh man, I messed up. Upadhyayula, right? Okay, I'm sorry. I'll work on that. I practiced all last night and I still messed it up. These are a couple of exemplary teams that, as I said, will share workflow modification. Their full bios will be shared with you to save some time. I'll just let you know that Dr. Lee is the owner of Vermont VO Pharmacy in Los Angeles, serving primarily a Korean Hispanic population. He has a lot of services that I just shared with you already going on. CRMC is new to him, but he's already seen a lot of improvement in his population engaging with the work of CRMC. Now Ramesh has been doing this a long time. He is just a fantastic role model in providing advanced pharmacy services out of community pharmacies. He is CEO of the pharmacy at Desert Hospital Outpatient Pharmacy. He owns actually several pharmacies and has offered all sorts of clinical services, in my opinion, well ahead of his time. He brings 33 years of experience in pharmacy practice from both inpatient and outpatient settings. So with that, I will start with Dr. Lee sharing his experience with workflow modification.
Good afternoon, everyone. Hopefully you can hear me. We can go to the next slide. So workflow, these were the main steps of the workflow for everything when we started was finding eligible patients to schedule, performing the CMM with the patient, documentation and billing, and then scheduling the next appointment with the patient. But before we even started that, you know, Dr. Chen pointed out a big thing, how to set up our pharmacy. We didn't even have anything. We were just a retail pharmacy, and what we needed was an office space. And so when Dr. Connie Chen, King and a few of the LA Care people came over to the pharmacy, they're like, what are you doing? Like, we need an office. And I was like, I didn't know we needed an office. So I had to take out one of our storage areas and take it out completely and make it into a complete office. So that was probably one of the biggest things that had to be done first. And then we can go on to the next part was the eligible patient scheduling. One of the key things that happened was the warm handoff. Before then, it wasn't done a warm handoff. We were just given the patient's name and phone number, and we would call, and that was it. Now we sort of have like a transition where LA Care calls us with the patient, and then we have one of our techs or our pharmacists get the phone call, and we get the patient information, and then we schedule an appointment on our calendar. During that time, we're trying to get all the patient information that we can so that we can get started. And some of the stuff we try to do to save time also is have their medications with them for that appointment. So this warm handoff has become really helpful because I think a lot of it is trust. You know, trust for the patient to trust the pharmacist and the insurance company at the same time, because you know everyone's new, you know, and you're trying to make this very smooth as possible. And so once everything's scheduled, that's when we go into the next part of performing the CMM. At our pharmacy, we have 3 pharmacists, two staff, and then I'm usually there. And then what we decided was to split it up between all 3 of our pharmacists of taking on patients. I thought having just one patient or one pharmacist to do this would have been a lot quicker, but I wanted everyone to be an advanced practice pharmacist by the time we're done and get this done. So we usually have a pharmacist and a technician who speak Spanish. Most of our eligible patients who for CMRMC is they only speak Spanish or Korean. So yeah. So we usually have a technician go in there because they're the ones who speak Spanish for us. Another benefit was with this meeting was having a pharmacy student. Where we contracted with USC, and we have now an API student who comes and helps out with the CMM. Either they're inputting data or they're actually taking the data from the patient. Actually, we had one of our patients give their data, like basic information, done by the student, and then the student presents to the pharmacist. And then if the patient doesn't answer when we're doing this, because right now they're not coming into the pharmacy, we call to reschedule. And we pretty much call every other day, different times, trying to find the best time to reach the patient and try to get it scheduled again. I think this part of performing the CMM is probably the easiest part, actually, of doing it, because we do a lot of clinical overview with as a group, weekly meetings. We're doing, case studies together. So it actually works out pretty nice during that time. I'm going to say I've done, I would say the first meeting with the patient is the hardest, because you're trying to get everything together and it takes the longest. But by the time the second time comes around, it goes a lot smoother. So every patient that we've done takes, the first meetings always takes the longest. Okay, next slide. Documentation with the MD for labs and medication background. This kind of takes a couple of days if you don't have a CPA or an EHR to go with the doctor. But we've been able to do it. It's just been like, you just got to stay on top of it. Some doctors are fast, some doctors aren't. Trying to get everything together and trying to have it all consolidated. But ever since the website has been set up, a lot of the stuff has gone a lot smoother, of trying to reach out to the doctors and making everything go faster and consolidating everything for the billing and documentation. So I usually have my pharmacist do the CMM, and then afterwards I have them stay at least another half hour to 30 minutes to just work on the documentation so they don't forget anything. So I think the first meeting takes about close to 2 hours. I'm not gonna lie. It took a lot of time just to get used to what we're doing, but it's moving faster. Every time we keep talking, we're trying to make improvements. Connie's doing a great job of making things go smoother for us. So I appreciate that. And so is Hannah also, who's part of LA Care. Billing wise, we fax LA Care afterwards as like a prior authorization, and they send it back us the authorization. We just bill it up through our pharmacy management program, and you see the money just come in. So that's really nice and helpful. I thought we would be doing Medicare bill or like medical billing, but instead we're using the pharmacy program, which makes things a lot smoother. Because I was afraid. I was like, I don't know how to do medical billing. So that's been really nice. Next slide. Scheduling the next appointment. That has been the tricky part, especially because we have 3 pharmacists doing this. Do we have this patient call back in a couple of days because it's something that's urgent? Do we do it a couple months, or is it spontaneous because we haven't been able to reach out to them? I've had all 3 where we had to call back in a couple of days because we needed to make sure everything was okay. Couple months if they seem stable and we can reach back to them, and then spontaneous because we couldn't get a hold of them and we just keep on calling and calling. They're like, this is my only time right now, and because of COVID, we just make it work, trying to get everything done. I talked with Dr. Chen, with Connie, and trying to find a way that's more, I guess, smoother of when we should schedule an appointment, and trying to talk with doing it as like a clinical standpoint. But for right now, we're trying to be as flexible as possible and try to get the results that we want. So that's what I've been doing at our pharmacy. If anyone has any questions, feel free to ask.
Eddie, that's all? No, that's amazing. You think about what we've done and what we've seen you do is just incredible, and you've been able to already translate that into some really exciting outcomes for your patients that you've shared with us. So thank you for sharing that story. Fantastic. I'm going to now hand it off to Ramesh to share his story. Ramesh, are you available?
Hi, can you guys hear me?
Yes.
Yes. Hi. My name is Ramesh Upadhyayula. I'm the pharmacist in charge at Desert Hospital Outpatient Pharmacy, and also director of our Desert Hospital Outpatient Ambulatory Health Services. We currently provide CM services at our patient pharmacy. We do oncology pain management. We do multi-state disease management, along with we just getting into now the TOC program with the hospital, with our residents, and our TOC pharmacists. Here I am to just complement to what Eddie has said, just add. Eddie has given a major workflow, but I just want to kind of complement his process. Here, I want to share with you our workflow for repurposing our pharmacy and strategies for developing CMM workflow at your pharmacy, and also strategies for refining your workflow. Repurposing the pharmacy involves many criteria. Can I have the next slide, please? It'll be mainly the workspace, time allotment, and staffing needs. Now you have to remember, for ages we've been in the dispensing mode. Now we're trying to go to both dispensing and the CMM mode. So it requires a different set of needs, basically. The workspace, we need a little bit more quieter space for extended phone calls during the CMM process, and also a private area for either inpatient appointments or nowadays telemedicine, obviously. As far as the time allotment is concerned, it is very, very important to break down CMM into several different functions. Some functions that can be done throughout the day, and some functions that are have to be time-driven or schedule-driven, I should say. For example, not as time-sensitive would be patient intake, or creating patient profiles, or prepping the patient for CMM appointment. So these are things that do not really need, not time-driven, but definitely can be done by ancillary staff that can prep up the patient for the CMM appointment. Now the time-sensitive ones are actually the CMM appointments. Now sometimes patients are time-driven. They actually want you to call at a certain time, certain date, and also this requires you to assess your staffing needs at that time, and have to be planned accordingly. Can I have the next slide, please? Now, this is something that you don't have to, you have to be creative to make the most of the space that you have in your pharmacy as far as the workspace is concerned. We had an old call room that we used to use, that we took out the calling area, moved it to somewhere else, and we repurposed that area to be our CMM quiet area where the phone calls could be made, and also in-person patient visits could be made. Can I have the next slide, please? So time allotment is very, very, very important. Time allotment, you have to determine how much time it's going to take you for CMM. What does it entail? It entails intake, CMM appointments, documentation, billing, patient advocacy. Patient advocacy is huge. Just because you have done a CMM does not absolve you of your responsibility of saying that I'm done with my CMM. Our responsibility goes beyond that, where we need to address the patient's social determinant. Patient needs any transportation, patient needs any help with to pay for the medications, or any other aspect that a pharmacy could come in and help. And also incoming faxes, emails, and calls. So as you could see, the intake, billing, and incoming faxes and emails can pretty much be handled by ancillary staff. And whereas the patient advocacy part a part of it can be handled by the ancillary staff. However, some of it has to be addressed by the pharmacist, and which is what you have to decide on, probably creating a checklist to see who will be doing what. It's important to see what time best works for you for each different activity. Here, downtime are between urgent dispensing tasks. So intake, billing, patient advocacy, incoming faxes can be done during the downtime, or can be done, they'll keep coming throughout the day. It doesn't have to be on a certain time. However, certain patient advocacy tasks can be done as an urgent, in between urgent tasks. One thing that we have figured out is it's like a two pharmacist model, where we assign the one pharmacist to have even hour appointments, and the other pharmacists will have odd hour appointments. That'll give roughly about 2 hours between each appointment per pharmacist. That allows us not only to have an appointment with the patient, but also gives us enough time to finish up our notes and also help up with the patient advocacy while my second pharmacist is ready for the appointment, for his CMM appointment. I can jump in and help him with the dispensing activity. Can I have the next slide, please? So the strategies to improve the efficiency, is like spreading out the CMM appointments, back-to-back appointments can be very difficult to handle. You have a lot of backlog, a lot of work pileup can happen. So to improve the efficiency, it's good to have a spread out appointments, alternating pharmacists. Using checklists. Checklist is the biggest thing that we can do, is where we all have the checklist, can go into the workflow, and everybody has, somebody is finishing up the intake, somebody's calling the patients for scheduling, somebody's calling, finishing up the patient information, basically it's a sharing of the workload. That's what the checklist allows us, and patient advocacy, of course. CMM appointment design, there's a fixed appointment, and also there is a daily list of patients. Some patients are very flexible in their appointments. They said, hey, you can call me anytime. Some patients are very set. So we try to kind of mix and match both kinds of appointments. So in case I cannot reach my scheduled patient for the appointment, I have a list of patients that's available that I can call on and finish up the CMM. This way, my time is utilized in a much more effective way. And also the team approach to CMM, just like we talked about it, sharing the workload, alternating tasks, and all those things come under the, and also technology part of it. This is what I loved about what IEHP has talked about it, about remote patient monitoring, allowing us to be able to see the patient, the diabetes readings or the blood pressure readings. And I can intercept with the patient if it's urgent, even without an appointment. I can just, as a follow-up call, in between my patients, I can just pick up the phone and call them. This is an amazing, the avenue that we have that's being provided to us through IEHP. We're really happy with that. Can I have the next slide, please? Staffing needs, again, this is, it's totally up to you. The sharing the workload immensely makes you very efficient. Drop off, call room, and our lead technician can help with the billing along with the other tasks that she handles. And our long-term care can also help jump in and help with some of the intake information. The biggest asset for us is going to be interns. The pharmacists and interns together handle the CMM appointments. And the documentation, we sometimes even let the interns do the documentation, but the pharmacist approves the documentation before it's finalized. So that way they get an experience on how to do a complete CMM as well. Our strongest point is going to be patient advocacy. That's where the interns come in and help us with a lot of patient advocacy that needs to help with the patient. Again, strategies for sharing tasks. Just like we created the checklist, breaking the tasks into smaller tasks, and making CMM a workload visible. What does it mean by that? It's like, when we have the prescriptions, the new prescriptions come in, we have a bin where the prescriptions go in, and the staff will take it as it comes, and then as they find a moment, and they'll finish it off. Similarly, we have a CMM workload bin where the checklist kind of go in, and based on the assignment as to who's going to be assigned to do that, the people will take the checklist and kind of finish off the task. That helps reduce the load on the pharmacist when it comes to completing the CMM for the patient. Can I have the next one, please? Refining the quality improvement. This is very, very important. By properly identifying the constraints that we have in the workflow, we can greatly improve our quality further opportunities for improvement as well. Kind continuously look at the workflow process and refine them, and rapid cycle improvement, rapid cycle quality improvement, define what we do, identify the areas of improvement, and how are you going to measure the results. Measuring the results is very critical. It's not just practicing CMM, but identifying the bottlenecks and how to resolve the bottlenecks. And also, how are you measuring the success? Pilot runs and check for the hiccups. Examine the results. Where are were the goals achieved or not? Is there any kinks? Fix it and do a pilot again. And finally, a successful pilot and incorporate that into workflow. It's a kind of process that's been working for us. It's kind of hard to kind of put everything in words, but this is where we are.
Thank you. Actually, oh, sorry, go ahead, Ramesh.
Sorry, rapid cycle improvement. Yeah, this actually tells you, what we just talked about, model for improvement, what are we trying to accomplish? How will we know a change has been in improvement, and what change can we make into the result of improvement? So basically, this is a PDSA cycle of improvement that we implement. Thank you very much.
Thank you, sir. Really appreciate both of you gentlemen sharing your workflow processes. I think there's a lot to gain from both of the sets of information you shared, and our ask you is not to answer any questions right now, but take a look at the resources that we have online at the CalRightMeds Collaborative, as well as in the practice alignment guide that we'll be sharing with you all after this call. And we'd like you to utilize it if you haven't started on a CMM journey to try to relook at your workflow and see how you could accommodate comprehensive medication management in your community pharmacies. So with that, I'm going to have to introduce myself and share screen. Give me 1 second here. Okay. So I'm going to spend, I'm going to condense this a little bit, but spend a few minutes talking about establishing collaborative practice agreements. This is something that I think a lot of people struggle with, and it's largely because there are certainly pretty much standardized templates for CPAs, but to get a CPA signed is different than just sharing a template. So I'm going to go into some of that a little bit here. So learning objectives you're already provided with. Before I jump right into CPAs, I thought it would be worthwhile to take a minute to cover some definitions that sort of frame the purpose of what a CPA is. So first term, scope of practice. I put in kind of some bolded letters and italics what it really means. They're boundaries within which a health professional may practice, but simply translated, it's what are you legally permitted to do, right? And so this is a State Board of Pharmacy issue, right? So you can see our State Board of Pharmacy has all these different elements to scope of practice. You all know what they are. I'm not going to repeat them, but it's basically what the law says you can do. When you go into credentialing, this is the process for confirming qualifications of an individual in a given subject or practice. In other words, what am I qualified to do? This is both a health plan and a health system process that can occur. Now, not always both, but it can be in both the health plan and the health system, as opposed to privileging. Okay, what is privileging? Privilege is the authorization you grant to a specific facility or institution for a specific person who provides specific services or professional rights. In other words, what am I allowed to do here at this specific location? That's privileging. And that directly connects to a collaborative practice agreement. This is a formal agreement in which a licensed provider makes a diagnosis, supervises patient care, and refers patients to a pharmacist under a protocol that allows a pharmacist to perform specific patient care functions. Again, going back, what am I allowed to do here is what we're talking about. So how's it translated into practice? Well, if you're as old as I am, you used to practice under a protocol. And a protocol is a pretty long document, a lot of details, has goals, roles and responsibilities, who's supervising, who's staffing, how do you enroll patients, how do you discharge them, what are the step-by-step decisions that take place for that patient. Could be an algorithm, could be first this drug, then that drug, might have a list of the drugs you can use. It's often condition or medication specific. That's a protocol. So when I first got out of school and did primary care, we practiced under protocols. On the other end of the spectrum is the collaborative practice agreement. How does it differ? It permits activities. It's not condition or medication specific necessarily, and it may just refer to guidelines or practice standards. In other words, it says, under this collaborative practice agreement, this health system, this clinic allows this pharmacist or this pharmacy entity to do these services, and then just refers to the guidelines. Now, what are the advantages and disadvantages of these? Under a protocol, physicians that you work with know exactly what you're doing because it's a cookbook, right? It's a step-by-step process. They know exactly what you're doing. There's that assurance on their part that there's no question about what you're doing, right? But on the other hand, it restricts your ability to practice clinical pharmacy, to practice comprehensive medication management and make decisions that sometimes don't follow that algorithm. And by the way, in most cases, protocols, guidelines, et cetera, do not apply to all patients, not even close, sometimes half or less. Now the CPA, on the other hand, one more thing about the protocol. The other thing about the protocol is because it's often medication or disease specific, you have to update it all the time, right? So big trial comes out, new guideline comes out, oh, your protocol is now outdated, you got to update it. That's an incredible hassle. Yeah, we did that for years. CPA, obviously, shorter document, completely aligned with State Board of Pharmacy scope of practice standards, does not require updating of the CPA because you're referring to guideline sources. You don't actually have them in the document. A lot of advantages. The disadvantage is what I said first about protocol, which is physicians who have never worked with a pharmacist may balk at it and may say, well, gee, I've never worked with a pharmacist before. And they can do what? They can change medications. They sort of get confused sometimes about what it is that we're actually trying to do and get nervous. So in between is something I'll call a blend, a CPA and protocol, right? Not quite as long as a protocol, not quite as short as a CPA, but this is what we've actually compromised on sometimes. So there's some elements of protocol specificity. What I mean by that is sometimes we name diseases, sometimes we name medications. But when we do, especially the medications, we just name classes of medications and we don't restrict the care to just that disease. So it's worded in a way where it sounds like it's a little more focused, it kind of is, but it's broad enough in language that it still allows you to do full CMM. And this is what we did, for example, in our big CMMI Center for Medicare and Medicaid Innovation project with Ultimate Health Services. We eventually compromised on the CPA/protocol because they were brand new to the idea of having pharmacists manage medications, fairly independently. But within a month, it gravitated towards full CPA because once physicians get a feel for what you're doing, they trust what you're doing, it very quickly evolves into the CPA direction. So I share this with you because if you're trying to establish a CPA and you're thinking, we're going to go with the full borderline CPA, it may not work depending on who your partner is. You may have to compromise and move kind of to the left of this diagram. I would say don't go the protocol route because it's a nightmare trying to keep updating that document as new evidence and new guidelines come into place. Just not worth the time. And you don't want to be caught into an algorithm. Because in the end, if that's the case, why are you doing this? Anybody can follow an algorithm. What you really want is that blended CPA protocol if you can't have the full CPA initially, which again, can eventually evolve into the CPA. And we have all of these examples for you through the Cal Right Meds Collaborative, through our website and other resources. So there are other resources online you can pull from, CDC, APHA, all have some really good guide sources on collaborative practice agreements. It's not that complicated. There are some components that are pretty standard. So some standard CPA components are who's involved. Is it a single physician, multiple physicians like in a group? Is it one pharmacist? Is it a pharmacy? Is it a group? Sometimes a CPA can have specificity about credentials and training for the pharmacists involved in care. It can be single patient, although I've never been a part of a single patient type protocol. I'm more involved in the patient population form, which makes a lot more sense. Although I have heard that some people have to practice under single patient protocols. It's just highly inefficient in terms of scaling this up and getting more patients enrolled. Services, it's again about permissions, performing tests, assessments, all related to medication therapy, modifying medications. Again, it's usually not condition or medication specific. It labels a supervising physician. Sometimes it's a single attending versus the patient's primary care provider. So in the case of a single attending, it might be the CMO, Chief Medical Officer, or the medical director, or somebody who's sort of that supervising physician entity. But again, in other cases, it might be the patient's primary care physician. It establishes frequency and form of communication, turnaround time for clinical documentation following visits. By law, that's within 24 hours, but we always try to do better than that. Again, medications, usually you try not to be too specific. Try to name drug classes, not limit yourself, as opposed to having to name specific medications, because when a new drug comes on the market, then you have to rewrite your CPA. And then, as I said, we refer to guidelines as opposed to actually trying to rewrite or reformat the guidelines and put it within the CPA. Liability is important, right? Physicians who embark on this, one of the first things they worry about is what's the risk to me? You're changing medications for my patients. You're doing things without me and my permission. Like how do I feel safe about that? I'd say that if your physician, partner, or medical group requires some details about liability, then you can put in things like your liability insurance and put in some terminology about a peer review process that will help assure them that what you're doing is perfectly fine. And as much as possible, I would align that peer review process with what the medical group already does. And then sometimes I'll reference state laws, right? Just to make it clear that this is in complete alignment with laws that support this work in the state. On rare occasion, we add in CE requirements if that's what the entity wants, almost never that I've seen. So really quickly, just a general CPA for CMM. Again, this is what we make available to our teams in the Cal Right-Meds Collaborative. Refers to state pharmacy law in the very beginning, goes through the purpose, general aspects of the kinds of things we're doing for the patient's education, adherence, med therapy optimization, guidelines for patients being referred, the clinic visits, the flow, the follow-up, just to make sure the physicians are comfortable with it. The different scope of services and the check boxes under C, quality assurance, as I mentioned before, of the program itself, documentation, then peer review, which occurs in this example quarterly. And then here are the references to the standard guidelines. And that's it. It's a really simple, pretty much can be applied to any setting. But again, it depends on the familiarity that your partner has with collaborative practice agreements. Just as a quick counterexample, something more specific, a hypertension medication management program. This is aligned with the late Dr. Ron Victor's barbershop-based hypertension program in South LA that he published in New England Journal of Medicine that was run by Pharmacists. So this gets a little more specific into the process, procedures, still references state Board of Pharmacy law, but goes through the different classes of drugs, the different functions that the pharmacist will perform, has even some technician duties outlined as to what their support role will be. It's very, very helpful, as you heard previously, in delivering comprehensive medication management. Goes through a pretty rigorous description of what's being done. Again, this is because in the partnership we had in this case, they wanted this level of detail for the pharmacist to move forward and be pretty independent. And like I said, drug classes, right? We didn't name specific drugs, we named drug classes. We didn't give an algorithm that was so rigorous that you couldn't have some flexibility. Now, this is literally what Dr. Victor and I sat down and sketched out really quickly and just, wrapped up, and that was it. We got these all signed by independent community physicians or private physicians that had never worked with a pharmacist before. So that's it for my brief overview. There are resources, like I said, on the CRMC website and in the practice alignment guide that can help you. So I would say if you're interested in learning more and advancing a CPA, read some of those references I sent to you, take a look at our resources, and get ready, because if you should join our collaborative, we would love to try to pair you up with a medical group or FQHC or other entity for which we can hopefully foster a collaborative practice agreement. Okay, with that, I'm going to stop sharing and introduce our final speaker for this segment, who's Adelina Ardelline. She is with Good Neighbor Pharmacy. She came highly, highly recommended by our own PR director as an expert in advertising at Good Neighbor Pharmacy. She has had extensive experience with AmerisourceBergen, a long career that we, like I said, we're going to share with you in more detail. But our PR director heard her speak once and said, you know, this is the person you need to have share tips on personal branding as it relates to community pharmacies, particularly in the context of the perception you're trying to create for your medical partners and for your patients and for your other stakeholders. So Adelina, thank you for joining us on such short notice. So I'll turn it over to you.
Thank you for having me. This is a very exciting opportunity for me. I hope my kids are not going to bomb this call for me. So if they do, you'll get to meet my lovely 5-year-old. We can get started. I actually have quite a bit of slides and I hope I'll be able to fit everything in 10 minutes. Next slide. What is your pharmacy brand? So your brand is more than just your logo. Your brand is technically the heart of your business. It is the promise you make to your patients. Without a brand, your business lacks an identified purpose. And without a purpose, a business can't stand out from the competition. Next slide. When you define your brand identity, as an independent pharmacy, you might already have it defined. You might have a strong mission and values ingrained with it. The question is whether you're communicating or living your brand. I'm glad that you folks are sharing these this deck, because these are, honestly, these are the most relevant questions and the most important slide that I have. So answering these questions, it's a good exercise for everyone who wants to assist define their brand. They're designed to have that self-reflection. And once you answer these questions, look at common trends between the answers, and they will sketch your brand identity. So now that you have a solid understanding of your brand, make sure that you document it and you share it with your staff, and then eventually your physicians and consumers. Next slide. On offline brand channels, these are traditional and considered offline channels that showcase your brand. So in-store experience, signage, a face-to-face interaction, print marketing, direct marketing, TV, radio, and print ads, as well as word of mouth. Next, these are your online brand channels. So social media, website, blog, email, mobile, local business listing, ratings and reviews, and as well as SEO. So looking at these channels, I want you to be thinking about your online brand and think about the areas where you can improve. Next. Creating a seamless brand experience. The main message here, consistency is key. Patients want to have a consistent experience with your brand, whether they're online or offline, on social media or on your website. Familiarity defines brand commitment. And that is why I started off talking about brand identity, because even though your online or offline channels have a lot of differences, your brand identity is going to be that connection. It's going to be what helps create that seamless brand experience that patients are looking for. Next. Impact of digital technology. Think about the ways our digital technology has influenced our lives. It has touched nearly every aspect of our lives, from the way we shop for our food, where we go, who we marry, what we wear, and how we connect with people. Next. You can see during COVID-19 pandemic, we have seen quite a substantial growth in the time that is spent online. So 16% growth in global web traffic between April and June 2020. 20 billion hours globally spent on apps in April 2020, and that's a 40% growth year to year, 82 minutes per day spent on social networks in the US. So that is a 7% increase from 2019. Next. Identify your digital champion. This is very important because this person that works for your team will maintain your online presence. They will run your social media account, your website, any online ventures that you pursue. It could be you, it could be a pharmacy clerk, it could be a tech, it could be an intern, whoever else that you might find fit for the role. You have to make sure that they have the proper tools and resources. First of all, they need a device, whether it's a computer or an iPad. Can you work with them to set aside a certain time a week to devote to this? Do they have did you have a discussion about your brand, how they should be presenting your pharmacy online? Next. Creating your online brand. Once your brand identity is defined, the next step is picking which channels you want to focus on. I suggest starting with social media. Media, it's accessible, it's affordable, and there's a lot of data proving that it's important for your business to be on social media. It's a great way to meet patients there. And the final step is, what are you going to share with your patients? And let's dive in. Telling your story with content marketing. Content marketing allows us to create a narrative and explain to people whether they are your patients or your prescribers or your local legislators, the story of your business. It comes in many forms, like a social media post, a graphic, an ad, a backstuffer, the text that you have on your website. It's really anything that you're creating for your patients, who you are, what do you do, and what value do you deliver to them. Besides patients, another important audience is your referral source, the prescribers. They need to understand the value proposition of your pharmacy and why they should send patients to your pharmacy. They need to have a crafted message that showcases the services you offer and how you positively impact patients' outcomes and bringing well-being to the community that you service. They want to hear directly from you, specifically the challenges you encounter when you're trying to deliver better care. And lastly, the local legislators. They cannot help you unless they really understand your business. Most of them assume that they understand community pharmacy, but they really need to be ingrained into your business to really understand the challenges and the goals of your business. Content marketing allows you to create a narrative and explain to people how your business fits into their lives, addresses their needs. And when you're creating this content, you want to be asking yourself a few core questions. You want to really assess the needs of your patients. And those needs should be curated with the appropriate content for them. Next, social media content and strategy. You want to share a variety of content, whether you want to promote clinical services, feature products, highlight information about pharmacy events. Make it fun too. Be consistent. Recommended post frequency is 3 to 5 times per week. It's actually okay now during COVID to post even 3 to 4 times a day, as long as you're staying relevant within your market. Show patients what makes your pharmacy special. Plan ahead by creating a content calendar and pre-scheduling posts. Use visuals like photos, graphics, and videos. Stay engaged, especially with feedback. So if anyone gives you a review, try to respond to it as soon as possible. Next. Social media utilization. You can see here 2 examples of pharmacies that are using social media to inform their patients about services during the pandemic. A pharmacy is now offering curbside pickup. Another one is offering drive-through service. A good way to update your hours, just letting them know through your social media channels that you have new hours. Next. This example shows two pharmacies that use social media to inform customers about the services. One of them is talking about the bigger screen. They talk about mental health during the times of the pandemic. And the second one, they're showing here different services that they're offering. And you can see different people within the store showcasing different parts of the business that are relevant to consumers. Next. Key performance indicators. How do you know if your brand awareness efforts are actually paying off? What metrics can you use to measure success in your branding efforts? And here are 3 key performance indicators. The number of impressions is basically how many people are seeing your social media content. They could be seeing once or twice or even more. Engagements, measure the number of actions. So people liking, reacting to your post, likes, sharing your post. And then here, the share of voice measures how you stack up against your competitors. Regularly check what they're posting socially and how their engagement levels measure against your own brand's content. As a final thought, please don't get caught up in the process. The metrics matter, but above all, tell people who you are. Showcase them your authentic self. Know that your imperfections make you human. And keep in mind, the people that you're trying to reach, especially when you work in local community pharmacies. And these are the sources that we use to put this deck together.
All right. Thank you. That was fantastic. And while you were speaking, a lot of great praise for your work. So you've certainly established your expertise and reputation already among this group. Thank you for sharing such great advice in such a limited amount of time. Really greatly appreciate it. So we have about 7 minutes to wrap up our session here. We have 2 questions that we're posing. One is, what did you hear that you can utilize or adapt to help advance your CMM program, using workflows, maybe CPAs? And the other is, what are 1 or 2 things you can do to advance your personal branding based on what was just shared? So a lot of questions already comments in the chat, but let's zip out into our chat rooms and have a brief that they just discussed, something they might adopt to advance their CMM program, or something they would like to advance in terms of personal branding. Does anyone have anything they'd like to share? Catch 1, maybe 2 responses verbally.
Yes.
Please go ahead.
My name is Kamlesh Mania, and owner at TLC Medical Arts Pharmacy in West Covina. Work in my business as old-fashioned way. My label says friendly old home of old-fashioned friendly service. Not doing any social media so far. Don't have a Facebook account. Don't have a Yelp account. Don't have a LinkedIn. Only old-fashioned way. But looking at today's Adelina's presentation, inspire me to go back and sign up for the Facebook, put some post on it, go on a little bit more of it.
I love it.
Now I'm going to do each and every patient at the counter, open up my medication bottle, show them the medication. Hey, this is your medication look like. That's I've been doing for the last 5 years.
Yeah.
Today's presentation inspired me to change something.
Thanks so much. Really love that story. And I bet you've gotten a lot of success from your current method. But I think I agree. I think it'd be exciting to see what happens as you adopt some of these best practices. Somebody I saw in the chat wrote a second ago that somebody, one of their insights shared was the value of pharmacy students. And we're hearing that an awful lot, that by having your pharmacy students rotate and provide really the highest level of support possible, I think, for CMM, really makes a difference. I don't think I mentioned it to this group, but in our CMMI grant, by having technicians, basically, students are much more advanced than pharm technicians are, but having technicians working in our CMM programs increased our daily capacity by 50% in terms of being able to see patients. So incredible investment. In the case of technicians, I'll say that they are often aligned culturally and ethnically with the community. So even better value in that regard. Anyone else? One more before we head off to a 5-minute break. Okay, hearing none. We're going to reconvene.
Can I suggest,
yeah. Oh, please go ahead.
Can I suggest we take a quick screenshot?
Oh yeah, that's a great idea. Absolutely. So
and speaking of tech, Kamlesh, I don't know how. I tried. It's me. I know it's not the system. Someone please do it for us.
Let's do this. Let's everybody, if you can turn on your cameras, we are going to take multiple screenshots of all of you. We have to do this, okay? We usually do a group photo, but can't do it this year. So
where's the camera?
The camera is going to be on. You're going to look right into the light on your laptop or computer camera. Take a look, everybody. Don't send any chats because those words are going to block my my screenshot. Okay.
That's why I'm not great at branding, because I don't know where the camera is.
Okay. Okay. I took one shot. I'm taking page 2. Taking. Hold on a second. Sorry, we're going to have to make this work best we can here.
You want me to do it, Dr. Chen?
Yeah, go ahead, because I'm going to. I was going to actually create a new. I got it.
Okay. Page 1, we're gonna do a smile, and I'm gonna count down to 3. Page 1, smile, 1, 2, 3. Okay, and then next page, you're gonna have to smile 6 times. Smile, 1, 2, 3. All right, smile for the 3rd time. 1, 2, 3. Smile for the 4th.
CRMC photo shoot.
I love it.
Smile for the 4th time. 1, 2, 3. And then smile for the 5th time. 1, 2, 3. And I have one last one. Smile, 1, 2, 3. Thank you.
Thank you guys very much. Okay, so Connie, with your permission, we're going to go to a break. Let's take, we're running a little, well, let's take Dr. Michelle Chu, Dr. Paul Gregerson, speaking about providing CMM care for the homeless patient population in general. And I'll tell you how this evolved is in speaking to our pilot teams, there was a request for more information about working with homeless patients and some assistance with it. And the first 2 people I thought of were Michelle and Dr. Gregerson. Dr. Gregerson is a national leader in the care of homeless patients. He's the Chief Medical Officer for the GWCH Institute, has faculty appointment at the Keck School of Medicine, is the leader of the Keck Student-Run Clinic, which is multidisciplinary, involves all of the health profession students at USC. He has a long list of amazing accomplishments. I've known this fearless leader of underserved care for now over a decade, and he has my greatest respect. As I tell him and other people, he completely changed my view of caring for the underserved. He has such a passion and commitment for it, and uncompromising commitment that I strive to emulate. He will join us shortly as in a Q&A session, probably in about 45 minutes from now or so. We're going to start off with Dr. Michelle Chu, who is a faculty member at the USC School of Pharmacy. I've known Dr. Chu my entire career because I recruited her as a resident, and probably best decision I've ever made. In her relatively short career, she has proven that she is able to adapt to any environment. Having spent time in the same clinic I did with Dr. Gregerson on Skid Row, the Center for Community Health, transitioned over to leading, being the frontline clinical pharmacist, leading the Center for Medicare and Medicaid Innovation, Healthcare Innovation Award with Ultimate Health Services, going to a private care, Keck Medical Center of USC, and now we're at LA County Hospital in their patient-centered medical home. Just a phenomenal patient care clinician, great teacher, great scholar. I couldn't be more proud of someone. She's already exceeding everything that I'm doing, so she can have my job soon. Anyway, she will be kicking it off by speaking of her experience in providing comprehensive medication management for homeless patients. So I will hand it off to Michelle, who will at some point then bring in Dr. Gregerson.
And I just wanted to mention Dr. Gregerson is with us already.
Oh, great. Fantastic. Okay, great. So I want to introduce him again. Dr. Chu will introduce Dr. Gregerson when she completes her section.
Well, thank you, Steve. It's really great to see everyone here on Sunday, and with your dedication to provide and run the CMM collaborative. So it's really good to see everyone. I joined a little bit, like a few minutes ago, before you guys all went to the breakout room, and I got to be on the screenshot, so I get the credit of the whole day participation. Do I share my screen? I thought I was, and then
yes.
Okay.
Thank you so much.
Okay, so give me 1 second. I'm sorry. Okay, do you see the full screen?
Perfect.
Yes.
Okay,
yes.
Awesome. All right. Okay, so hi, well, thank you for the great introduction. I probably won't have Dr. Steve Chen's job soon, anytime soon. I still have a long way to go. But thank you for inviting me here. Just wanted to say that I have no disclosure. So today is the next about 30-40 minutes. I wanted to share my experience working with a homeless population. These are the learning objectives for the talk. So before I begin, I kind of wanted to get an idea of what your initial reaction is when you are seeing a homeless person on a street, at a market, social media, or if you don't want to share yours, what do you think the general public's initial reaction is when they see the homeless people? And this is probably, you can just think of any, your personal life, like outside of the work. And also, can you share any story about a homeless person that you've heard from social media or news outlets, or through a personal experience of working with them? So let's take a just very brief, like 30-20 seconds. And then if anybody can kind of shout out to share their story or their reaction. And it could be, there's no judgment here. So just to start off, my initial reaction the very, very first time that when I saw the homeless person was a little bit, I was scared. And then obviously, working at the CCH, the Center for Community Health Clinic, which is on the Skid Row, changed my whole view about the homeless person. So if you can, either chat is fine, and I am trying to monitor the chat as well.
Yeah, and we'll also monitor for you, Michelle. But as Michelle says, if you have something you'd like to say, please unmute yourself, and or otherwise you can type in some comments in the chat. So far, William Coe has shared more cautious.
Yeah, right. So that's how my initial reaction was, like a more cautious, and I was, like I said, a little bit scared at first. What else? Anybody else?
This is Debbie. I always think, and I think I've become better, but psychiatric, like mental illness type issues and unpredictable.
Right. So that's it is unfortunate, right? So with a patient who has a mental illness and who does not on medications, or maybe they might be on medication, but they're not adherent to it, right? And then that the psychiatric conditions can be very unstable. I see the very fragile community. They need our help. That the worry that I make some recommendations that are not possible for the patient. I think a lot of avoiding eye contact, and then mental health and self-medication and the drug substance use disorders. So these are definitely legit concerns, right? Does anybody have any story to share that maybe you had personal, like working personally with them, or maybe something that changed your initial reaction?
You know, Michelle, this is Debbie again. I just have a quick story. It wasn't really as a pharmacist, it was just as a person walking down the street. And where I was frequently is this area along the San Gabriel River where homeless people would walk and sleep and stuff. And there was one individual that would walk along and he would always make this kind of noise like he was a machine and rah, 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 rah. And so one day as he was walking by, I just said, "Hey, hi, how are you?" And he just stopped and he looked at me in a very normal voice. And he said, "Well, I'm good. Thanks for asking." And then kept on. So it was like, you know, you don't know what's behind it. And, you know, it was like, he was so normal once he turned and talked to me for that 2 seconds.
Yeah, I no, totally agree. I think every single one of them, they have their own unique story, and we don't know their story, how they became, you know, how they got where they are now. So I think that's very important, and that definitely helps us, give us a little bit more insight when we care for the homeless person. So the Los Angeles Homeless Services Authority just released, probably back in June, that they counted the homeless population, and it was about 66,000 or 66,500 people in Los Angeles County experiencing homelessness. And this is actually about 12 to 13%, you know, rise from the last years at the same point. So, you know, we wonder, like, why is this happening? Why is this increasing in homeless population? Homelessness is very complex, right? It's not just about the unemployment, stagnant wages affecting housing, high rents, and a shortage of affordable housing. Those are not the only contributors to this crisis. Many Americans find themselves homeless as a result of debt or drug or alcohol use, domestic violence, mental health problems, institutionalizations, and limited family or social support. So like I said, every homeless person has his or her own unique story. So just to share very few of those stories is that one of many the patients that I worked with back at CCH, he used to be a lawyer and he got into a drug use. In a habitual drug use, and he got incarcerated, and after that he lost everything and he became homeless. I know a patient who was a successful business owner before. He got separated from the family, unable to overcome those barriers, and became homeless and just lost everything. Other people who was involved in the street gang activities too early on during his childhood, and he's been incarcerated repeatedly, and he lost contact with his family members, or probably didn't even know what happened to his family members. I'm not sure, but in the end, when he got out of the prison, he had nowhere to go, so he became homeless. Successful professional working at Wall Street, right? But then something triggered his underlying mental health disorder, and he lost everything, became homeless. I think in this type of story, you probably heard it from like Instagram or Facebook or even news outlets. So a lot of also the women, homeless people, they have a childhood trauma, domestic violence, sexual abuse. So they just couldn't, they had to get out, and then they run away and they have nowhere to go. So it's really just every single person has a unique story. But it's not about just the home, not having home, not being able to afford, those mental illness or the drug use disorders. But it's really compounded by challenges accessing adequate healthcare services and maintaining good health. So about 50% of the homeless population utilizes ER as a primary source of care. And of those people who comes to ER, majority of them are coming because of the poor management of the chronic disease. Some of them are coming from the psychiatric illnesses, and believe it or not, about 70% are coming from the depression, and then 27% are suffering from the schizophrenia. Substance use disorders are also common. Majority of it is for the alcohol use, and then some parts of the heroin or cocaine use. A lot of, especially the older, the homeless population, they utilize ER a lot because they have the cardiovascular complaints and the injuries. And then, you know, it is shown that the homeless population who utilizes the ER, they have multiple visits within just the 30 days. So we have, and so in fact, they have tremendous difficulties, right, of getting this care. And the reason is they probably have multiple barriers to the healthcare access. So they're less knowledgeable about how to navigate the health system. And even us, it's really difficult for just average Americans to navigate the healthcare system. And even having insurance, it's such a difficult task actually to understand how the claims work and how everything works. They also have a poor understanding. They have a lack of access to the healthcare. They don't have insurance, obviously, and they don't know how to get help, and they don't know where to get those resources. So consequently, many homeless individuals have worse health outcomes for preventable conditions when compared to the general populations. So today, I wanted to speak a little bit about my patient interactions at CCH. So CCH is a Center for Community Health. It's a part of the JWCH Incorporation. It's literally located in Skid Row. So it's actually between 5th and 6th Street on San Pedro, if you guys want to visit. The clinic is awesome. It's a true patient-centered medical home. So it has primary care, dentistry, optometry, behavioral health, social work, dispensary. At the time when I was working there, now they have a pharmacy, and then also provided clinical pharmacy services. So I think before we go on, it's important to understand what the Skid Row is. If you look at the city data, you can see that the population in the Skid Row is really dense. It's about more than 3 times of just in general population in LA County. And if you look at the race, the Black has about 45%, Hispanic or Latino is about 20%, white 20%, and it has all other races composing the whole population. And you look at the ages. Most of this homeless population in the Skid Row is usually between 40 and 50 years old, and it is predominantly male. So you can think that if you're a female and homeless and you're in the Skid Row, it could be a little bit scary because it's predominantly male. It's very their thought process is very traditional. So it could be scary, but I think you will understand if you look at these individual patients, and you will understand that you know, not everyone is that scary as they look at. So how did I start here? I started my residency training. This was actually Dr. Chen's clinical practice site, and I was just fortunate to be his resident, and I got rotated there, and I just fell in love with the patient interactions there. And you know, obviously, like Dr. Gregerson is here today, we had a very strong physician support. So I really fell in love with the clinic. So what did I do? I provided CMM my half of time. The other half of time, I managed a dispensary. At the time, I precepted the students and the residents, and some of all the residents are here on the call too today. I was participating in the PNT just to manage the formulary, the QI, the quality improvement initiatives that I was involved in. And also there are some existing patient support groups, but I also provided additional services for the support group as well. So just wanted to, I'm sure that you probably went over this, but I think when you are establishing yourself as an individual or when you are starting a new clinical pharmacy services, you need to, so important to identify champion physician. And then when you work, when you have a good relationship and partnership, strong partnership with the champion physicians, that tends to spread to other physicians and clinic staff and clinic operation. So kind of knowing what the clinic needs in terms of a quality performance metrics like A1C, blood pressure that they need to meet, statin use, any medication safety that needs of the clinics or the physicians or even the patients. So for example, if there are the drugs that needs a more close monitoring, such as INR or diuretic use in heart failure patients, those are great examples that you could probably start with. Patients who has multiple medications or they have multiple different providers, because the homeless population, they tends to also migrate. So they, not on purpose, but they tend to have different providers as well as including the specialists. The medication access needs are definitely important for the patients. So at the clinic at the time, we did have a 340B medications, and we heavily utilized the patient assistance program. I know that the patient assistance program probably have changed a lot over the years, and but at the time when I was working there, the status of the PAP on the medication would change frequently, so that we had to monitor that. And if one medication is not available for PAP, then we would look at the 340B medications. If the cost is still an issue, then we would have to kind of set the tier 1, tier 2 type of formulary within the clinic. Flu vaccine, I mean, the clinic definitely tries to provide, flu vaccines to everybody who comes to the clinic. Sometimes, we aren't able to, but we don't stop there. We don't say that, hey, we are out of flu vaccines, that you have to go somewhere else. We provide flu vaccine vouchers at the time. So we had some program with, I remember it was a Rite Aid or one of the chain pharmacy that we had partnered with to provide a free flu shot for the homeless population. So these are kind of the things that you might want to think about back in your head when you're starting the services. Not only having the partnership with the actual clinic and the physicians who work at the clinic, but you definitely do need a partnership and collaboration with the clinic staff as well as outside of the clinic, outside of providers. So we had team huddles, I believe it was every 2 weeks or every month or so, on a very, very complex patient cases to discuss the care coordination and to manage his case. The other specialists and allied health care providers such as LCSW, those are the clinically licensed clinical social workers. So those are sort of similar to the psychologist, and also working closely with the psychiatrist because we have lots of patients with a mental disorder. So, but most importantly, the partnership with the patients are important, right? So how do we develop the relationship with the patients as a group? We started the diabetes health fairs, and for the existing patient support group for the diabetes, you would go in there and then provide some in-service to the patients. The USC students group, pharmacy students had the smoking cessation program, and I believe it is still going on to provide the smoking cessation and help them to, stop smoking at the clinic. And also by USC medical and pharmacy students, they used to have a monthly presentations on the disease states, the medications, to increase the awareness and to provide more information to the patients. So, so that was kind of like a very quick summary of how, I build the partnerships and then the collaboration between the clinic and the providers as well as the patients. But if you really think about just one-on-one interactions, what factors should you consider when providing CMM or just when providing any care, right, healthcare to this population as a one-on-one interaction? What kind of things do you need to consider? So I thought it would be great to have a breakout rooms here, discuss it among your groups for 5 minutes, and then we'll come back at 2:57 to the main room, and then we can debrief. Is that okay?
We had a very rich discussion in our breakout, and I think we're going to turn it back over to Michelle to continue. Is that right? Yes, here she goes.
Sorry, I didn't know I was on mute. Yeah, so hopefully you guys had some great discussions. Can anyone share what you guys discussed, either on the chat or you can unmute yourself? And
I feel like, hi, this is Ramesh. I feel like gaining the trust of the homeless person is very important for them to open up in order for us to provide a proper CMM. That relationship needs to be established. They need to feel like, you're not coming in with some kind of an agenda towards them. Be open.
Right. No, I totally agree. Yes, it's really difficult for them to trust anybody due to the experience that they had with other people. So, and they really do have they have a mistrust in healthcare system actually. So whatever we try, so for example, we try to offer, hey, instead of this drug, let's use this drug, for example, because it's more safe and it's a lot convenient for you and it's no cost to you, but they still sometimes refuse, right? Because they think that, oh, you are providing this drug because you are getting some money, from the drug company. So yes, the mistrust on the healthcare system is really, really big. And I think I see more chat coming in. So yeah, so my group also talked about the medication storage. A lot of people they don't have the refrigerator at home or even kitchen, right? So they weren't able to cook for themselves. Stolen medications, that's totally, it's always happening. Some people, they are even afraid. Back then it was, everybody, more people use the insulin syringe instead of the insulin pen back then. And I'm talking about what, between 2009 and 2011. So, some people would not want to start insulin because they don't want to carry around their syringes with them. They didn't want to be viewed as they're using a drug. So that was one of the biggest the challenges. This is really interesting. The opposite of theft, homeless patient may be given meds from another homeless patient, and then that doesn't belong to them. That happens all the time. It's a huge education point. They don't understand. So about the expiration date, they don't understand the dose is very individualized, especially the insulin. They don't understand how to properly store the insulin or even any other medications. You know, some medications have 2-3 different indications for it, right? And just because one person is using a medication for one reason doesn't mean that the other person can use that for a different reason or that reason. And they don't, first of all, they don't really know what they actually have, right, in terms of the condition-wise. So yeah, that's definitely the safety issue right there. So are you guys seeing the full slide? Okay. So then how do we partner with the individual patients? I think that's pretty much the focus here, is that obviously we need to earn their trust and the respect. And how do we do that? We do that by listening, understanding, and accepting their lifestyle. Every single lifestyle of them are very different, and they have their particular way that they like to do and they want to keep doing. They don't like changes. So, you know, sometimes we have to be very flexible. We have to accommodate to the individual needs. The social factor is a huge problem, especially no access to the fresh fruits and vegetables, no access to the kitchen. So placing them in at least the temporary housing could provide them, you know, with the shared, at least the shared kitchen or at least the cafeteria that serves the food. And every single time we provide the therapy modifications or even just education, always include the patients in that decision making, right? We can't, even though we try not to do that, sometimes they come in to the clinic as with a view of, you are the clinician, I am the patient, so I am inferior. That's how they sometimes come in. So we have to break that barrier. And it's very easy to break that barrier, right? It really depends on our attitude toward them. So if we are more, if we act more of a coach rather than I'm a clinician and you're the patient, you do what I tell you to do because this is safe, I know better. They already have that sort of the impression of what the clinicians would think. So they are, you know, homeless. So they already feel very inferior. So we don't want them to feel inferior at all, right? So we have to bring ourselves to their level. And then obviously, like I said, be flexible at times. So important. Sometimes maybe the drug therapy or the way the medication needs to be taken might be a little bit out of the norm, but that's when we use our drug info skills and researching PubMeds and try to find other resources where if we can, you know, try to, if we can meet the patient's needs and their requests. Okay, so I know we just came back from the breakout rooms, but I have like 2 more breakout rooms. So, but I think this would be a very great example. So this patient she's a mid-40s, a heart failure, Hispanic female with diabetes on insulin with elevated A1C. A1C is greater than 10%. It has been unsuccessful placing her into a permanent shelter or housing placement. Even she would, and then it was partly her choice and also partly because of the qualification that she didn't meet. So what she does is every single morning, sometimes she's, lives on the street. Sometimes she goes and finds the temporary shelter, and every morning she walks everywhere. She there's no aimlessly, really. She just walks. She has no phone. She does have a glucometer because the clinic provided to her, but she doesn't use it. She has all the testing kits, but she doesn't use it. Her most recent labs was within normal except blood glucose and then A1C, fortunately. And at the time, available diabetes therapy for the patient was basically insulin, like NPHR, insulin pens, analogs, and then also metformin. How would you approach this patient to manage her diabetes? And what other factors should you consider when determining diabetes therapy for this patient? So instead of going into the breakout rooms, because we just came back from the breakout room, why don't we kind of take a few seconds and think about this and then share openly as a big group?
Yeah, so feel free to chat or unmute yourself if you'd like to respond. Thank you.
Say the first thing to do would be to collect some more information. What are her personal goals? What are her barriers? Why isn't she using the glucometer? How does she feel about injections? Has she ever tried metformin? I think that's where I'd start.
Yeah, that's great, right? So we need to find out more about the patient, right? Like we have to really understand what she's doing, where she's going. I mean, what is the path that she's taking, right? Like every morning is she passing by our clinic? Like how come she's so good at coming to the appointments, but then she doesn't do any other stuff, right? For whatever reason. So we need to find out what her daily activities look like, what are her routine looks like, right? What is there anyone who wants to contribute or participate?
Hi, this is Bao from IBHS. Can you hear me?
Yes.
Hi. So I have dealt with homeless patient within my pharmacies, both inside CMM and with just like a regular pickup at the consultation window. I saw that there sometimes the number one concern is like food, transportation, where I'm going to sleep tonight, not necessarily medication. For this lady, she's using insulin, but she doesn't have a permanent shelter. So the first question that pops up in my head is how she gonna store insulin. She doesn't have a fridge, looks like. And then her regimen looks like it's all like NPH and insulin R. And then you also have metformin on the board. So I don't know if she's like type 1, type 2, or can we do something like, like a once a week regimen for her, like an Ozempic, maybe better for her, I don't know. But yeah, these patients are sometimes very complicated, and it's just more than medication. So yeah, that's my take on the case.
Yeah, that's exactly right. So you hit the spot right on that their concern is not really health or medications. Their concern is really like the food, sleep situation, right? And am I going to get attacked by other people, right? Because they are living on the street. So those are the biggest concern. And we, the education, about the food is great. Education about other stuff is great. Education about the, being aware of the diabetes is great. But we also need to make sure that their primary concern has been met. So this is why we have to collaborate with. We can't just do it this on our own and with just the physician, right? We have to talk to the social worker. We have to talk to the people who has all these resources for these patients, so that at least they can get rid of, they can fulfill their primary concern. So this patient, I did ask her that, where does she walk? When she walks, the path includes our clinic? Does she always pass through our clinic? And then she said yes. She always, that's why she doesn't miss the appointment. So then, okay, then how do you use insulin? Because you were already on insulin, so how did you use that? Where did you store it? she just carries it with her, right? But so I had a feeling that she wasn't really using it. She didn't want to use a glucometer. She didn't want to check herself because obviously she knows about the, clean hands. She didn't have an alcohol swab. She has nowhere to clean herself during the day, right? And also she didn't want to have any, like other people seeing her pricking her fingers or injecting insulin because of the stigma about the drug use. So then what, we discussed with the clinic nurses and then the clinic operation, and also because I was in the dispensary, so okay, that's okay, then we'll actually store the insulin for you, and you can actually come in every morning when you pass by our clinic, just come in without the appointment. Our nurse is going to check your sugar, and then our nurse is going to inject your insulin, okay, for the day. And at the time, the Ozempic, that would have been awesome therapy, but at the time that wasn't available. So we were able to switch her to the pens through the PAP, the Patient Assistance Program. So we worked with her and basically kind of accommodated to her daily life. I think that was sort of the main point here. So just a few other examples. The poor health literacy is sometimes it was actually beyond my imagination. This patient, a mid-40s African-American male who has diabetes and a mental illness, he was incarcerated all throughout his childhood and adulthood. And then this was kind of the first time that he got out and he wanted to make a difference, right, in his life. His education level, unfortunately, was a second grade. He can't read or write. He has no family members except the aunt, unfortunately, who was actually taking him in after he got out of the prison. So it took me and our resident a whole good year and maybe year and like a few months in order for his A1C to bring it down from 10 something to less than 7. And in the beginning, it was a little bit difficult, right? Because he didn't understand a lot of things. He didn't understand even the basic stuff. And there was a lot of things that he didn't trust, whatever we say about the health. But I think he's, with his aunt's help, he was able to still come to the appointment, and he's actually enjoyed the appointments. And he thought that was a good, positive routine for him. So he started coming in more and more. I saw him every 2 weeks and then extended out to every month, ever since he has been better and more adherent. And then, I think the main point here is that it takes a long time to really bring bring them down to the healthy level. Another quick example is a mid-40s, Mid-Eastern male with diabetes and mental illness. He was new to Skid Row, but he was, walking around with a blood glucose 300 and 400s, and he was always been fully adherent to the medications. So his primary care couldn't really figure out why, and why his blood sugar was always high. So he was referred to us. And further interview, I find out that he's actually eating 1 loaf of bread every meal, and for the snack too. So he thought that was good, because before he used to eat just a variety of food that was given by the shelter cafeteria. But because of the diabetes, he thought that all the food had sugar, but he didn't know that the bread had sugar. So he cut out everything, but he was so proud of it. I cut out soda, I cut out all the sweet things, but he also cut out fruits and vegetables and just everything. And then he was just eating 1 loaf of bread every single meal. And, we did provide education. It was a lot of education. And then, his sugar went down to 100. So he was so thankful. All that stuff is really the education, right? So asking further questions, trying to get to know what they're doing, how their lifestyle is, I think it's really important and crucial. So another one, due to the time, I think I'm just going to tell you guys,
I'm sorry.
Yes.
Unfortunately, yeah, we are out of time completely. So we do need to I'm sorry to interrupt, but yeah, like I know you were also wrapping up.
Yeah, so yeah, I think it is a type 1 diabetes patient who has a Medicare. His blood glucose was actually really good, A1C 7.6. It was very adherent, but he had frequent hypoglycemic episodes. So we did provide, the education on like, how about we, nowadays we have this, you don't have to poke yourself all the time, right? So you can wear it, the continuous glucose monitoring system, and the Medicare covers for it. But he did refuse, even though he was only able to check 4 times a day at least, at the most. And the reason is because he didn't want change. He doesn't like the changes. He doesn't like the new technology. And that's something that we need to consider when we care for the homeless population. So sorry that I had to rush, and but I'm so excited to introduce Dr. Paul Gregerson. Dr. Paul Gregerson is the Chief Medical Officer at the John Wesley Community Health Institute, and he and I worked really closely when I was there at the clinic, and he's really the reason why all the clinic members, all the providers are still there providing care for this homeless population. So let me stop sharing my screen. And so Dr. Gregerson, are you here?
Yeah. Hi, Michelle. How are you?
Good. How are you? It's been so long.
Well, nice to see you, and hi, Steve. Nice to see you. It's a pleasure to be here today. Michelle, I can tell based on what I just heard the last 30 minutes that, or 45 minutes, is that everything, your time spent at our clinic was very well spent, because you understand this population. You gave some very good examples, and it's very clear, and even the audience participation, it's very clear that people understand that with homeless, there's a different mindset, and that trust is of the utmost importance. And once you engage these people, and that may take longer with this population, that it will pay off in the long term, because once you get trust from this population, compliance goes up and a lot of other things start to change. But it's a process, and meeting the population where they are is so important, and considering their comorbidities is also a very important component of dealing with this population. And I heard that from the participants today. Michelle, you did such a good examples of a few patients that really are representative of the population. So kudos to you. And I have to say, when Steve and Michelle and Julie Dofidi is another pharmacist on the staff at USC were coming to our clinic down in Skid Row, medication management really, really made a difference. And, we had such good outcomes. Better outcomes, control of not only, chronic disease, but mental health issues was very apparent. So never underestimate the importance of pharmacy in the overall care of this population, and as a member of the interprofessional team, because without you, physicians could not do the job they do. And especially with, patients that are so complex and have so many problems, it takes many people to focus on, these people's problems, and a team approach and an interprofessional approach is of utmost importance.
Yeah, no, I agree. I think this is not a one man's job. It's really the collaboration with the different team members. So Dr. Gregerson, you've cared so many homeless people, right, at the CCH and also other clinics. Can you share maybe one patient that's like enlightening, memorable to you?
Let me answer that question by giving me my perspective about this population and why I started working with this population and why I still love it today. And that is that with so many of these patients, and you gave examples yourself, Michelle, so many of these patients have comorbid mental health, substance abuse, and a lot of it's, mental health can be genetic, and there's an environmental component to mental illness. And so many of the people that are homeless are the victims of, being at a bad place in life, whether it's growing up in South Central LA with a mother that's schizophrenic and a father that was never around, and gang members that entice you to join because you have nothing else, no education, nothing to look forward to, an environment that's not nurturing. And so when I started working with this population, and then on the other hand, let me just say, there's women too that have been abused and, sexually abused, physically abused, emotionally and mentally abused. And, the thing that really touched me when I started, when I first came to Skid Row was that this population, despite all the things that have happened to them, and there have been stories that I've heard that are just unbelievable, and you empathize, but you can never really fully understand the pain that these people have gone through. But what really touched me was that despite these hardships, these people have persevered and are actually looking at their glass as half full. They're not looking at the fact that they've been abused and victims, and they're just thankful for having the opportunity to live another day. They're so spiritually enlightened about life, and that just really gave me a sense of fulfillment. And I always got the impression as a doctor that the success of what I do was based on how well I controlled somebody's blood pressure, or if their diabetes was under control, or what the outcomes, whether HEDIS measures were accomplished or health outcomes were better. But I learned from working with this population that it's really, that's a very small component of it. And really it's about being able to go home at night knowing that, I made a difference in their life, and that, either the quality of their life got better, they felt like they were socially supported in some way, because some of these people really do have no social support, nowhere to go, nobody to talk to, no personal possessions. So, but they're spiritually very alive and believers, and thankful for the fact that they're still alive and living another day despite everything that's happened to them. And that's been the reason why I've been so enlightened myself and inspired to work with this population. And it's, even today, 20 years later almost, I look just as forward to going to work and talking to these patients as I did, when I first started. So that's why. It's their perspective and perseverance that really has given me the same thing.
That's really wonderful too. It's true, because this is the place where I learned to be very humble about how I got here and all that stuff. Like these people are very hopeful, and it just they teach me, actually, instead of me teaching them, about the diabetes. It's the other way around, and I actually gain more than what I give to them. So unfortunately, though, the number of homeless people were, already on the rise before the pandemic. What do you think the biggest challenges with providing care to the homeless before and then after COVID-19?
Well, that's a question. I think the best answer to that is that, resources, lack of resources, and, dealing with that has always been our number one challenge as an organization. And that comes both in terms of resources to buy materials and provide services, but also finding the right employees to work with this population. And so resources, like I said, is our number one challenge. I think when COVID came along, and stay-at-home orders started to take effect, we saw visits go down, and then resources became an even bigger problem. And, I think it caused us as an agency to really quickly refocus our patient flow. And luckily, at the same time, there was an emergency order from Washington to allow for telehealth during the COVID pandemic. And so that's pretty much what we've done. We've basically redesigned the care system to basically be based on a lot of telehealth. Probably 70% of our visits right now are telehealth. And the difference was, I think telehealth is here to stay. I think it's a great way to do care, especially for vulnerable and indigent populations that have so many barriers to getting to the doctor to start with, or the doctor's office. This allows us, and really what I meant when I said that there was an emergency order, it meant that, previously Medicare had said that you can only bill for services if it's a face-to-face encounter with a patient. And this allowed us to do basically work with this population or any of our indigent or homeless patients through telephone or video. And we quickly redesigned the system to be able to do that because, keep in mind that a lot of this population that's most vulnerable are, well, elderly, not so much with the homeless because, as we know, the homeless die at a younger age. The average life expectancy for homeless is probably early 50s. We do see a lot that do live well beyond that, but again, it is a risk factor. And also those that are also have comorbid conditions and are immunocompromised or have other vulnerabilities, we're told to shelter in place or stay at home and not come in the clinic. So this really gave us an opportunity to stay in touch with this population, not encourage them to come in for care, and gave us the opportunity to do as much as we can by either telephone or video. Most of it's been, I have to say, telephonic up to this point. And for the homeless population in particular, many of them don't have Wi-Fi. A lot of them don't have internet access. But the one thing we have found is that most of them do have a phone. And, and even, throughout the years, we've had agencies that have come in. Even the health plans have made sure that as much as they can, patients have access to phones and that they're able to be contacted and connected. So that's what we've done throughout this pandemic to basically change the way we do care. It has been a challenge because the pandemic has gone on longer than we thought it would. It's now, 6-7 months, and it doesn't look like it's going to be gone anytime soon. And it becomes much more difficult to do preventive care and get accurate blood pressure readings, blood sugars, hemoglobin A1Cs, cholesterols, all the things that we need to make decisions with medication management and care for this population. But it still is, keeping in touch with the patient and encouraging them to either go into their local pharmacy, find a way to get, when they do come in, making sure they have glucometers, making sure they have blood pressure machines, pulse oximeters for those that are high risk or vulnerable, things like that, and getting information through those means has been, also very helpful. And like I said, this is where pharmacies come in, and pharmacists can make a big difference because not being able to go to the doctor doesn't mean that patients won't go into the pharmacy to get their medication because they actually need them. And so that's an opportunity to get their blood pressure checked, their blood sugar checked, immunizations given, and a lot of other things that patients have not been encouraged to do by going into the clinics.
Lastly, what advice do you have for our pharmacist participants with limited experience caring for the homeless?
Well, I think you said it very well, Michelle, and that is that, and one of the gentlemen that answered the breakout question said it very well, that, trust is essential with this population and engagement is essential with this population. And, I think that once you understand that and you consider these patients have comorbidities and competing priorities being drug addiction, mental illness, nowhere to live, no social support system, and understanding that if you meet them where they are and you are flexible, all things that you said and I heard during this first 45 minutes, and you remember that it will really make a difference in your ability to be successful with this population, because the time, you know, like I said before, I think all of us have this goal where it's, you know, focused on outcomes and improving, you know, blood pressures and healthcare measures. But for this population, survival and living day to day is more their mindset. And if you are flexible with them and, you know, meet them where they're at, understand there's no wrong door, so to speak, and treat them, you know, like we all do as healthcare professionals. This isn't even something I need to tell anybody, because I know that pharmacists are so compassionate anyway, and healthcare workers in general are compassionate. But you know, in these hard times, a human life is a human life, and every life is very valuable. And if you treat people that way with dignity and respect, and no matter what, just do that, then you'll be very successful. Maybe not the first time you deal with these patients, maybe not the second time, and you may not find that these patients are consistently the same person every time they come in, because their moods change, their goals change, they're thinking about different things every time they come in just to survive. That you will do very well. The other thing I would say is that, you know, I think going forward, that, you know, the importance in healthcare of the pharmacist as a member of the interprofessional care team cannot be understated. And, you know, the mere fact that you're doing this learning session, and that pharmacists are becoming more and more a major component and part of the healthcare system is so good. It makes me just so heartened to know that there's, you know, 150 people here on a Sunday afternoon learning about medication management, and especially even with a population that so many people don't really understand or know that much about. Spending time on this one population really also heartens me. But my one piece of advice is, remember, you're a very key and integral part of a team that, with healthcare these days and the complexities of healthcare and the comorbidities that all patients have, not just homeless patients, that there needs to be a second eye, a third eye, and oftentimes a fourth and fifth to sort of, number one, engage the patient, because any one of the people on the care team may be the main person that engages people long term. And secondly, that you know medications and the side effects, and a lot about chronic disease that doctors don't know. And so, you know, doctors make mistakes. Doctors prescribe drugs that have interactions and side effects that are not good. And you picking that up and being able to suggest and help with the management of these patients is just so critical to making sure that the best health outcomes do actually occur. So that would be my my take home from being here.
Yeah, well, thank you so much.
Thank you. And like I said, it's great to see you, Steve.
Good to see you.
Good to see you too. Thank you so much. I think you all know why I adore these people so much, and why I say that Dr. Gregerson changed my perspective completely on caring for the underserved. He has so much wisdom and compassion and great advice to share. Thank you for that, Paul. Really do appreciate it very much. You know, I think I saw something in the chat, if you mentioned it, that for those of you that had some misconceptions about homeless patients before, when you start to spend time with them, you realize that they were just like you, that in every way, that there were maybe a few bad turns, unlucky occurrences in life that set them in a slightly different direction. And that's what I learned very quickly. When I first started working with Dr. Gregerson, he told me, you're going to be very surprised at what you see. And I was, and in the most pleasant way. So the best part of my patient care career was working with Dr. Gregerson and Skid Row. So again, thank you both so much for sharing. We are now going to move into our real breakout sessions, where we're going to divide this group into the group that is with us as a pilot, and the group that is not with us as a pilot. So I'm going to hand this over to, I believe, Dr. Diane Yoon, who's going to give us instructions on this part. Oh, can't hear you, Diane.
Let me
yeah, there you go.
Myself.
Yes.
Sorry, I just shared my screen earlier. I'll show it again. So you'll see that we're going to be moving into the breakout sessions. We're almost there at the home stretch. It's been a long day, but a great day full of just really amazing speakers and valuable information. So we have a breakout session for an hour, about a little less than about 55 minutes, and then we will return back to the main room. So at this time, we would like to have the pilots who are involved with CRMC to move to session B. So if you don't have the Zoom link, it's I put in the chat as well as on the slide for the topic keys to providing effective follow-up care. And then the rest of the participants will be remaining in the current room that we're in now, and will be participating in the session promoting patient self-management for culturally diverse populations. So we have a couple minutes just to transition because we want to get started right away, because we want to return back to the main room, which is the Zoom link that you logged on to for today by 4:30. So let's we'll have a little less than 55 minutes to be in our breakouts, but we want to make sure that we return by 4:30 so that we can have enough time, but also hear remaining important announcements and just wrap up, because I know Dr. Chen will want to just reconvene and also have a time for us to just wrap up as a large group. So right now we can move forward with transitioning to breakout sessions.
All right, so while Bianca is, oh, I actually already see it. I'll go ahead and quickly introduce myself, and I'll also let her introduce herself, and then we will dive right in. Our goal is to definitely have you all back by 4:30. So we're gonna try to kind of rush through our content because we do want to spend a good portion of the time, at least 15 minutes at the end, where you'll go to breakout rooms and kind of discuss everything that we talked about and how you're going to take that home and apply it to whatever work setting you're working in, whether you're already providing CMM or you're in a dispensing pharmacy, or you're retired and just doing other initiatives around pharmacy and healthcare. We really think this information can be applicable in any setting, so that would be the goal. My name is Jessica Abraham. I am a clinical pharmacist that works for the USC School of Pharmacy as their Director of Population Health. And I have a variety of background, ranging from doing clinical pharmacy and care services with an Ultimate project that Steve Chen led, and then went into managed care and pharmacy administration. And now I'm back to USC kind of directing various pop health efforts, including our California Right Meds Collaborative with Steve Chen. And Bianca, if you could just introduce yourself.
Hi everyone, my name is Bianca. I'm a recent graduate from the USC School of Pharmacy this year, but while I was in school, I was actively involved in the CRMC for student projects, and I was so fortunate to continue after I graduated and started doing fellowship with them. So I really find that CRMC goal really aligns with me to optimize patient health outcomes. So I'm really happy to be here and share some of the presentation with you guys.
All right, next slide. Okay, so just quickly our learning objectives, just to set the framework, we'd like you to be able to provide culturally sensitive care to diverse patient populations, recognize and overcome personal cultural biases, and then incorporate proven techniques for patient engagement. So as you can see, these are things that you could potentially apply to various settings. So starting with this quote, just to set your mindsets, it's much more important to know what sort of a patient has a disease than what sort of a disease a patient has. And really what this is saying is clearly that it's very important to know your patient, especially right after the session we heard about the homeless population from Michelle Chu. It's more important to know about your patient and their needs and their priorities, and what everything, how everything is important to them, their lives, their settings, socioeconomic, cultural, than to just know the disease that you're treating, because with that impacts everything else that you're going to do. Next slide. We'll kind of start with this, and for these questions, if you can just type into the chat, and then we can kind of gauge what kind of responses we're getting. These are just to help keep us engaged and kind of preface each section of content that we'll go over. So just definition question, what is cultural sensitivity or competence? Is it referring to respecting people with any cultural background and creating and fostering an atmosphere of non-discrimination in society? Is it being open to the idea of changing cultural attitudes? Is it the traditions, beliefs, customs, history, etc. of a group of people? Or is it just knowing about some cultural characteristics, history, values, beliefs, and behaviors of another ethnic or cultural group? So I'm just going to look at my chat. Okay. So yeah, so most of everyone got it. It is, next slide. It is A, and really the important thing to hone on here, some of the definitions sound similar, but we'll go through them, is really that cultural sensitivity, cultural competence, which has been kind of most recently lumped into one term, is really taking it into action. So actually respecting the people with any cultural background and creating and fostering an environment where you're able to do that. So quickly, just definitions. So cultural, we know, is really everything about a person. I think a lot of times we think of culture just as like your traditions and beliefs, but it's your customs, your history, folklore, religion, values, food and drink, arts, really everything in this spin wheel that you see. And then cultural knowledge is knowing, just knowing about some things of various groups. Many times people within a culture don't even actually recognize the things that are unique to their culture. It's really the outsiders that recognize these things. Next slide. And cultural awareness is kind of the next stage after cultural knowledge, where you're understanding that there are going to be differences between cultures and groups, and really hone in on the last important thing, which is cultural sensitivity and competence. That's what we hope that everyone kind of walks away from this session, starting to think about things they can do to be cultural sensitive and competent in their practices. This is where you add operational effectiveness to your practices, whatever you're doing, in whatever setting that you're doing, that you're taking that knowledge and that awareness and you're actually applying it and doing something so that your practices and the services you provide are considered culturally competent. Next slide. So this checklist is for cultural awareness, but it actually brings up some really good things that we just need to be mindful of, regardless of what groups of people we're working with. Establishing clear communication. This includes knowing your patient's preferred method of communicating and arranging professional interpretation if necessary. Realize that not all patient populations actually prefer to have a professional interpreter. Some prefer that if you speak the language a little bit, even if you feel like it's not to the extent and level it should be, they actually prefer to speak directly to the provider providing them the services versus having like a professional interpreter called in. So it's important to really understand your patient or understand your client and knowing how to communicate with them. Again, being aware of nonverbal cues without jumping to conclusions. This is important again. Some may like eye contact, some may not, depending on their culture. Some may like to shake your hand versus hug versus kind of have a barrier between them and the provider. For number 3 and 4, it just points out that we don't know everything about every culture, and sometimes we don't even know about majority of the patient population's culture that we see, but it's okay to ask. So with number 4, using normalizing statements and asking, for number 3, asking openly about people's traditions and customs. So a nice way to do it is saying something like, a lot of my patients have customs or practices that are so important for me to know about it, so I can make sure to give you the best possible care. And patients will respond and kind of tell you, maybe what they believe about insulin or what medications they prefer to take versus not, or how their diet is and changes that they can't really make for religious reasons or whatever it is. So those kind of questions are really important in that first interaction with your patient, so that you learn about your patient, again, knowing your patient versus just the disease that you're treating. And then last, examining your own biases, and we'll have another slide later about this, but many times we have unconscious biases and you don't really know that you have these until you take like a survey or something to show you what your unconscious biases and prejudices are. And that will really help you when you take those surveys and you see them, you become conscious of them, and you implement that when you provide care. Next slide. This is just a model just showing you the continuum of the definitions we worked on. Again, at the far right, remember that cultural sensitivity and competence, this is where we want to get. We want to use our awareness and knowledge, but actually apply it. So operational effectiveness is where we're trying to get. Next slide. And then this slide just gives you more principles, and really, because these slides will be provided to you after, I won't go through all the text, but again, keeping things in mind when you're trying to become culturally competent and sensitive in the services you provide. So things like valuing diversity. So not just knowing that there's differences, but like valuing and seeing the importance of it and showing that you really respect the differences from your own culture. Conducting that cultural self-assessment. So like I had said, I'll give an example later of a very popular way to look at your own unconscious biases and prejudices, and understanding the dynamics of difference. Sometimes we don't even realize why certain cultures behave the way they do or believe certain things that they do. So it's important to ask, it's important to do your research, to read about the background and the history, because sometimes that will provide so much insight to you that you'll be more understanding and insightful when you're working with that given culture. And then institutionalizing cultural knowledge. So again, that's what I was just talking about, researching and training yourselves and staff. Many times we work in environments that don't spend much time about cultural knowledge and awareness. So if you're in a leadership position where you can disseminate information, involve your staff in trainings, etc. And then adapting to diversity. So of course, taking everything you've learned and trying to really apply it to the patient care you provide. And at the very end, we'll summarize just some examples of things you can do if you're providing CMM services or clinical pharmacy services where it helps you become more cultural competent. Next slide. So this question, I'm not going to read through all of this, but I'll let you guys read it and then just start typing your responses in the chat. So it's just which of the following statements is true, and it gives you a few different statements about minority groups to see what you think would be true and which would be false. Take your time to read those. All right, so I see the responses, and it's actually D. So it is all of the above. This was interesting to me to read because I didn't realize that about all these cultures, but it's important to know because this just shows how important it is to implement cultural competency and sensitivity, because we have all these groups, African Americans and other ethnic minorities, reporting less partnership with physicians, less participation in their medical conditions, and lower satisfaction of care. So just provider satisfaction, quality of care satisfaction scores were lower when these groups were asked. Again, otherwise, compared to other minority groups, Asian Americans are least likely to feel that their doctor understood their background and valued them. And they reported that they felt like their doctor looked down on them. And this is an important one too, because I have some students that work in my virtual pharmacist care center who are Asian, particularly one who's Vietnamese, and she's a student, but our patients actually liked collaborating with her and discussing their healthcare with her more so than they did with their physicians who are medical doctor physicians, just because of the cultural competence and sensitivity that she had as a pharmacy intern student, than a physician who was, knew so much more and could do so much more for them. But just because they felt like they weren't understood, they weren't valued or respected, they tend to be much more open with her, and she's able to make medical changes for them that were impacting their adherence to medications and their outcomes. So it just shows how important. And then last here, African Americans, Latinos, and Asian Americans are more likely than whites to report that they believe they would have received better care if they'd been treated by a different race or ethnicity. So again, these are all stats from different studies that show that really patients do value feeling like they're understood from a cultural perspective, from a socioeconomic perspective. They feel more empowered in their relationship with the physician and in their care. Next slide, please. So this slide just summarizes again, why is it so important? Definitely will improve our health consequences, our outcomes, quality of care, and patient satisfaction. Next slide. So this is a quick video. Let's go ahead and play it. And then I think most of my other slides are actually summary slides, so I'll be able to skip a bunch of slides after this video. Bianca, are you able to play it?
Let me bring it up.
He was telling me about physical symptoms, but to me it sounded like a mental health problem. It was hard to switch the subject.
She has diabetes, but she grew up eating this way and didn't want to change.
I believe eye contact is important, but she wouldn't look at me. When I tried, it just got more uncomfortable.
He refused medication. I don't know why he was here if he didn't want help.
How you speak, what you hear, what your patient wants, and the expectations you both have are all shaped by culture. Culture impacts everything we do, including the symptoms that patients report and the treatments that are planned. Understanding and attending to cultural differences is known as cultural awareness. It doesn't mean that you know everything about every culture, but it does mean that you understand your own culture, know that it is different from other cultures, and are mindful of the cultural interaction between you and someone else. Here are some basic ideas that can improve cultural awareness between provider and patient. Culture includes everything. Nationality can certainly influence a person's culture. So can language, religion, race, ethnicity, sexual orientation, gender identity, age, profession, education, military status, nutrition preferences, pain tolerance, and thousands of other factors. Each of these cultures overlap and influence one another. Culture defines us. Cultural identity provides rules, expectations, and tendencies that influence human behavior. Verbal language, body language, and how someone understands symptoms are each culturally informed. Culture impacts the medical assessment. Some cultures understand and discuss physical health problems much more comfortably than mental health problems. Some cultures won't acknowledge physical pain, but look for a quick fix to a symptom that is bothersome. Your diagnosis must consider and include the countless cultural variations that inform your patient's understanding of the problem. Culture affects treatment plans. Try to follow the line from culture to person to symptom to treatment. For example, culture affects diet, which can cause symptoms, which determines treatment. And that treatment must be understood and accepted by the patient. Culture also affects how someone discusses and experiences mental health concerns such as depression, anxiety, or grief. A provider must be able to identify possible cultural elements in the patient's presentation in order to provide a relevant and reasonable treatment plan. Don't be afraid to ask. As vital as it is for a physician to understand how culture impacts your work, it is equally as important that you feel comfortable asking your patients how it matters to them. You can bridge the gap significantly to ask something as simple as, what does this mean to you? Culture is both limiting and limitless. What a person says and what you hear are each shaped by entire personal histories rich with cultural influences that are present whether they are named or not. If you are mindful to be culturally aware in your clinical interactions, you will be more attuned to what the patient wants from you and how to provide it. It's just good practice.
All right, thank you. All right, I just really like that video because I feel like it kind of sums up everything that we just talked about. But I will go on, and I know I'm short on time, so I'll be rushing these last few slides. But this slide is really just to show you, I know we've been saying culture, culture, culture. It's also social factors, economic factors. A lot of times people put socioeconomic separate than culture. Sometimes everything is lumped into culture. It's just really important to remember that it's everything. Every patient, every person comes from all walks of life and is individual and different in so many ways. So you want to look at everything. And over here you see in this education, occupation, income, gender, ethnicity, race. So you really want to take everything into consideration when you're looking at your patients and providing services. All right. Bianca, you can skip to my last assessment question. So it's like 3 more slides. These slides are just, again, telling you to look at everything as part of culture and socio and economic factors. So this slide is a small case. I just want you to take a look at it and see if you can apply kind of what we've talked about to know what choice would you select. I think it's a pretty obvious and easy case, but it just shows that we can kind of apply what we've learned so far. And of course, you can type your responses in the chat. All right, thank you, everyone. I can see the responses, and I was just reading a few comments before that. So yes, definitely it's B, and it's looking at the things that, you know, everything this patient tells you, from being the fact that they work 12 to 16-hour shifts, 6 to 7 days a week, taking those things into mind rather than just his uncontrolled diabetes, and giving him a plan that would be adaptable to his life. And everything about him. It's not just that he's a Latino patient. Many times that's what we think when we're dealing with culture. You're, and let me go with it that way. But that it's really looking at him, and many people who fall into this group, maybe young people who fall into this group of being extremely busy, working hard, strenuous jobs, 6 to 7 days a week, not being able to maybe check their blood sugar all day or have frequent in-person visits. Maybe they don't need much more exercise than what they're currently doing in their jobs, taking all of that into mind. So that's the correct response. And then I'm going to summarize with my last slide, really just bringing this back to CMM, even though maybe not all of you are providing CMM, maybe not all of you are pharmacists in this group that I have, because I know I have everyone who's not a current pilot site, so I know you come from different backgrounds. But this slide is just to show us, so for CMM, we've gone over these 4 steps in the past with our groups. These are kind of the 4 steps of CMM, with patient assessment, and then an evaluation of medication therapy, development and initiation of plan, and then at the end, follow-up and medication monitoring. There's a session that I give about how we can incorporate technicians and pharmacy interns and students in this CMM workflow. And what's important to know is, like, a fantastic easy way to increase being culturally competent or sensitive, or cultural humility, like I saw in the chat, is incorporating other staff members that you have that maybe are better, more culturally aligned to patient populations that you serve. So for example, I have a virtual pharmacist care center, and though I'm not Vietnamese or African American or Korean or many of the different cultures that we deal with, I have a lot of interns that come through, and I have pharmacy technicians who are Spanish speaking, and different groups of the people that I have on my staff are actually better aligned to our patient populations, and we use them as much as we can to kind of impact those groups of patients. And it's actually worked really well so far in terms of being able to connect with patients who really, other than the contact they've had with us, have felt kind of ununderstood or distant or not as active in their care. Then when they finally got that connection from someone who spoke their language at least and understood what they were saying without having to call in an interpreter, understood their diet, understood their religion, understood their work schedules, or their a typical day in their life, better than I could understand. So really using all of your staff, that's just one example of a way to go towards becoming more culturally humble. Different techniques in this little workflow. So you see like patient assessment. These are areas where our interns and our technicians can definitely support patient assessment, and they are able to, take into consideration the culture when they're collecting that information. They're more empathetic, they're understanding when collecting the subjective information. Evaluation of medication therapy. Again, here's another area where we use both interns and technicians, depending on what step it is. So our pharmacy interns are able to think of medications that are appropriate based on the cultural medical cures, religion, et cetera, of a certain group. Our technicians can sometimes think of why a patient is medication non-adherent to their medication, or having issues with cost. Our patients open up more to some of our technicians about those things, and then we can help them with cost issues for their meds. Developing and initiating a plan. Again, your medication therapy can be tailored to the cultural needs of the patient and the plan as well, whether it's medication, exercise, diet recommendations, all are impacted when you look at this diagram of everything that's in culture. So really everything you do, including even the follow-up, so to the last point, everything you do for the patient in CMM, you can leverage other staff that's more culturally aligned to your patients to help ensure that those recommendations you're making, the plan that you're making, the partnership that you're establishing with the patient to improve their care is doable for that person. Not just based on their language, but based on their lifestyle, their language, their religion, their manners, everything about them, socioeconomic and cultural. So with that, I will pass it on to my colleague, Bianca Lee, and she will dive a little bit more into now patient engagement and how to get the patient engaged well, considering everything we talked about culture.
Thank you.
You're welcome.
Okay. Can you guys hear me clearly? Awesome. So while you're looking at this question, just wanted to recap, and thanks Jessica for explaining how being culturally sensitive and being able to recognize and overcome cultural biases are all important components to shared decision-making model. And I do see you guys putting on the answers right now for D. Yes, shared decision-making is a tool to engage with patients, present options to patients, and establish partnerships. So I personally myself as a strong believer that it doesn't matter how good a drug can be, if the patient doesn't want to take it, it would be no use to optimize patient outcomes. So when we're thinking from a healthcare provider and when we're practicing CMM, we've heard from the patient testimonials from Crystal saying that we want to try to engage with more patients because through establishing partnership, exchanging these information, and weighing the options that patients have, we're able to come up with a decision together with the patients. Now, we saw the video, but let's dive in more to why patient engagement is important through some facts and studies. So With patient engagement, patient can feel more empowered. We've heard it repeatedly today. And this can also enhance patient and provider communication. This is the most core steps for us to start building that trust in the relationship early in the phases of CMM, as what Dr. Paul Gregerson has mentioned. And when patient feels activated, it actually increases patients to be more willing to manage their own care, leading to improved quality and more efficient care. And overall, with these results, it actually leads to positive health outcomes, better safety, better wellness, and also help in terms of lower the healthcare cost. Now, there are multiple frameworks for patients to engage at different levels. Some involves in the organization level and some involves in the policy making. Today, we'll be more diving into the direct care. And this part really showing us that in terms of patient engagement, it is involved as a continuum stage, starting from the very beginning when the patient is informed about a diagnosis, all the way to the point where they're involved and when the provider asks the patients about what are their preferences and treatment plans. And finally, based on the patient's preferences, some of the evidence-based medical and clinical judgment, we can then share the decisions and come up with a decision that's best for the patient. Also, keep in mind that patients comes from all different backgrounds, just like what Jessica said. They have different social determinants of health. They believe in different things because of the culture. They have different types of health literacy and education, as well as their social norms are completely different. So just be very mindful when you're participating in the CMM service, and really think what's appropriate for that patient is him or herself to do the self-management. So this is the last pre-test question. I promise you it's the longest one, but feel free to take a look and type the answers. Select all the apply, so it may be more than one answer. Okay, I hear some A, B, C, D. So the answer is actually A, C, and D. Why B is not the one is that because experts, the answer is experts recommend providers to challenge their patients and encourage them to take larger steps. It can be really tricky because our goal with CMM is that we want to come up with a tailored treatment. We want to come up with a tailored treatment plans. So which is why we don't just have one plan and make it fits all for every single patient. We have to be very mindful about that. Sorry, there's a car passing by. Okay, so after discussing the importance of patient engagement, we want to dive deeper into patient activation. Patient activation is part of patient engagement, but this part really particularly assess whether the patient, him or herself, has the knowledge, has the skills, has the confidence to really manage their own health and be ready to take part in control of their health. And as a healthcare provider, we want to emphasize and encourage patients to play a more active role to take care of themselves and manage their health. And there are actually multiple reasons, so I'll be spending the next few slides to discuss what are the benefits of patient activation involving multiple stakeholders. So from a patient standpoint, when patients are more activated, they're likely to be more engaged in preventative and healthy behavior, likely do more screenings, more immunizations, And then they're more likely to check on their diet and exercises, just want to be healthy in general. And they're 2 times more likely to prepare questions going into the office and be ready to seek more information on how they can achieve a better health. And at home, they're more likely to comply with treatments and do more self-monitoring. So Dr. Ed Jai earlier said that there are some technology advancement right now for the IEHP side, wanting to encourage more at-home monitoring. So this would be even more beneficial if those are available, and patients will become extra activated too. And several studies have also been done showing that different disease states of showing patient activation has confirmed it is positively related to self-management. And this is a good thing because like studies totally have these results to show that patient activation is a good thing, and it's not just what we heard from the patient testimonials, and it's actually been seen. Okay, from a quality care standpoint, patients that are activated are likely to have their disease states achieved within normal limits in terms of managing their BMI, A1C, blood pressure, lipid panel. They're all within normal limits. And with that, they're likely to have a better relationship with the physicians just by sharing their experience. And we can totally relate to that from the video earlier. The patient just kept talking about Crystal was so amazing. And just knowing how, if we can get more patients like this, we as healthcare providers can make such great impact on patients, and really appreciating all the work that we can do for them. And definitely from a financial standpoint, cost. With patients that are more activated, for those studies that were done in Minnesota, it showed that the ED visits were likely to decrease versus the patients that are less activated, they're more likely to drive healthcare costs. So this is something that are what we would expect, and that's what we would hope, especially from a health plan standpoint, that we want to drive down the cost of healthcare. So when we think about what can we do to actually achieve that, like given all these possible positive results when providing CMM services at a community center, is that again, we want to establish a partnership with patients to build a trusted relationship. And I'm sure as community pharmacists, we are pretty good at doing that, because I'm sure y'all have experience dealing with your day-to-day patients who really enjoy coming back to your pharmacy to get their medications refill. And then the next key part is really exchanging information based on what the patient knows and what the provider knows, through medical knowledge and using reliable and relevant resources for treatment options. And by braiding all of these together, we can weigh out different options based on patients' preferences. There are social, cultural factors to come up with a final decision. And by following this model, our goal as CMM is to build trust with patients, get them involved to do a treatment plan that they feel they are empowered to be involved in this decision-making process. So then they're willing to take the medications, they're willing to take care of their health. And when they feel engaged, when they feel activated, they're able to manage their health, manage their medications. The likelihood of positive health outcomes are way higher, and the spending for healthcare would be way lower. So before I move on to the next slide, I have a question and wonder, have you ever tried to get someone to do something because you know it's for their own good, but they won't listen when it makes you feel very frustrated? Like maybe when you want to tell your kids to eat more vegetables and stop eating sweets, but they won't listen to you. I actually recently had an experience like that. So my grandma really likes watching Korean drama, and back in the days, it was just DVD before Netflix even started. And when Netflix started, I wanted her to say, oh, let me teach you how to do it. And it's only 3 steps, right? Downloading it from the App Store, log in, and you can start clicking what you want. 3 simple steps, but my grandma, she's 80-something years old, and she doesn't know how to do it. So I was willing to spend the time to do it. I was willing to repeat it so many times. But at one point, she just said, well, Bianca, I just don't know. So it's okay, maybe next time. And I got a little frustrated. I'm like, why? Like, I'm trying to help you. Like, why won't you let me help you? And I think like this type of concept happens on a day-to-day basis, that you want to help someone, but sometimes they just won't listen to you. And this concept definitely applies to when, as a provider, trying to be the positive advocate, trying to like really care for your patients and help. But you kind of have to step back and really feel, are you trying to be the helper or are you trying to be the guider? Because as a helper, you will be someone that is, the patient should voice their reasons for change, not the practitioner that's voicing the change. Because if you do so, the patient will feel very angry, very defensive, uncomfortable, and powerless. In my scenario, my grandma didn't even want to try because she just feels like it's fine like that, like without the Netflix, so she doesn't need the account. Or do you want to be someone that's as a guider, that you really listen to what your patient needs, so then you can help make the decision together, and then so a patient will feel more engaged, and then they feel like, oh, you're listening to them, and eventually they will open and they will open up to you and tell you how they really feel. So I think that as clinician, we are trying to be responsible for responsible for someone's health, but it's 50-50 that it's just not the physicians to do their job, it's also the patients. So with that, I just hope that it kind of keep this image in your mind as you guide your patients in the future. Think about which type of role you want to play. And hopefully it will be someone more like a guider role, because it will be more likely to fulfill the self-management responsibility, and they don't feel like they're being told to do what you're telling to do. And that's it. So we have a few questions and reflection. So right now we'll put you into a breakout room, and then the questions you two, the whole group will be discussing would be, what can you bring back to your pharmacy practice to provide culturally sensitive care to diverse patient populations? And then the second one is, if you were to provide CMM services, what techniques would you use to engage with patients to promote self-management?
Yeah, since we only have 6 or about 10 minutes, we are gonna just go into breakouts for 3 minutes, and then when we return, we'll share as a group. Sure. So for just 3 minutes, we'll be in breakout rooms.
Sounds good.
Okay, and I think Marielle is going to set that up right now, so you'll see a pop-up on your screen that asks you to go to a breakout room. Not sure if it's working. It's not working for me. Okay, there you go. You can see it now. All right, so let's dive right in, just because I do want us to at least have the last 5 minutes just to discuss and debrief, and then we'll be going back to our main room. So I know everyone is from different backgrounds, so if anyone can just jump in, either question is fine, whether it's what can you bring back to your pharmacy practice or whatever practice you work in to provide culturally sensitive care to diverse patient populations. What are some things you think you can do that might give us all examples of things we can do in our practices? And if you were to provide CMM services, what are some techniques that you would use based on the information Bianca gave about engaging patients to promote self-management? anyone that can chime in. I'm sure there's no wrong answer. And I know
I've been more vocal, even though I'm older than most in the room, but I think for number one, I would probably say increase my awareness, or be willing to increase my cultural awareness so that I can increase my cultural competency. And the other thing, to the second question, it would be, when I learned or engaged in this to begin with, it was motivational interviewing was the buzzword. So I think building on that, you know, and realizing that every patient encounter is unique, and just trying to be more sensitive to people, especially in what we have going on in society now, and trying to break some of those barriers with my privilege relative to that, in terms of dealing with all kinds of people, not just people of color, but everybody who's involved.
I would share that most of my background is with Hispanic patients, and simply making an effort to start the conversation by greeting them in their own language. I don't know if that works with every culture, but definitely with your Hispanic or Spanish-speaking patients. They really appreciate, even if your accent is terrible and you can't hold a conversation, just starting out with an effort of greeting in their own language. It shows that you care, and it helps establish that trust.
Definitely right. I couldn't agree with you more, because I remember my clinic days were with Spanish population, and I was very limited. I just took Spanish in high school, but it's funny how much they appreciated. They really didn't even want the Spanish translator in there with us unless we really weren't understanding each other. But more or less, they really appreciated me trying, and them explaining, and them throwing in their English words where they needed to. They just felt like they had a closer relationship with me and understood. And then I'd bring in my technician when I just wanted to like really ensure that they understood like treatment recommendations and monitoring and things like that. So I definitely agree with you.
I agree too. I worked for a while in a Hispanic neighborhood, and it's like you meet them halfway. And then, like you said, Jessica, when you get kind of worried, like I can't possibly get this concept across, you bring in the tech, but yeah.
Yep, I couldn't agree more.
Although other languages might not be as easy to do that with, but.
Hi, this is Ndokako Malo. I'm with the California Department of Public Health. Everything I heard today actually echoed a lot of work we've been doing in California Department of Public Health. Just to give you one example, I used to be the evaluator for colorectal cancer screening program in the department. And last 2 years, we had a site visit with one of the health centers we're working, which is at South Central. And one of the questions I posed to the medical doctors, I said, what are the priority top list barriers that their patients are facing? They actually said they coined it post-treat traumatic syndrome, meaning that patients don't even pay attention to colorectal cancer because there's already a high list of social determinants they worry about before even considering colorectal cancer. And I believe that kind of sentiment applied to a lot of chronic condition, a lot of program we're trying to have patients adopt. So now sharing all those experiences, I think it's very important that we should always consider where the patients are and try to meet them where they are. And that include all this cultural sensitivity and every other social determinants of health to be able to make this a reliable and realistic approach.
Thank you. I agree. I think everyone's insight is just great. And it's just, you know, re-emphasizing everything we've already talked about, meeting them halfway, understanding them, understanding that every single patient is different. It's not even just language or just ethnicity that you come from, but so many different things. And taking the time during that first interaction with the patient to ask as many questions. It's not offensive. If anything, they appreciate that you're taking the extra time to understand them and not just dive into their uncontrolled disease state, but instead, you know, understanding them and making a connection with them. So that you can meet halfway and really be that partner, that helper, the guider versus someone who's just, you know, shoving down recommendations down there.
And I would like to add something to what everybody just said. Just would like to mention to you that more pharmacists are graduating with some Spanish knowledge. And I don't know how many schools out there offer a Spanish for Pharmacists course. I just want to let you know as a group that USC does offer Spanish for Pharmacists, and this is going to be the 4th year that they offer it. So there is more interest in cultural sensitivity and creating those, overcoming those barriers with patients. So, so hopefully, the future looks better.
That's great to know, Retta. When I was in pharmacy school, I didn't really actually have that, but what helped me was during residency, where we had a lot of tools and resources to use when conducting visits in Spanish. And then when you're doing it every single day, and those terms kind of become, the frequent knowledge. And like Debbie said, when I was like, oh, I don't know if I'm getting the real message across, I need to bring someone in, they kind of always saw me and my technician as the team. So we worked together when I needed the extra support, but much of it I could do based on just learning the usual kind of Spanish terminology around a lot of things. So it's not that hard to learn, but for some languages beyond Spanish, it probably is. So you do need, for example, like that Vietnamese student that I have, I could never do anything in Vietnamese, but she is able to bridge such a gap in therapy for my entire Vietnamese population now. And now she volunteers for us, even though she's still completing pharmacy school. And we kind of leave all the Vietnamese patients to her and have her help us bridge the gap there.
Yes, I agree.
All right, so I think we're in the main room, so we don't have to move. Everyone's going to be coming into this room. All right, there we go.
We're already here listening to y'all.
All right.
Okay.
And I see people are coming in, so we're admitting.
Yes, thank you. Okay. So I noticed that, I don't know if you guys are watching the numbers, but we probably had a high of somewhere around mid 130s or so in attendees. That stayed until probably the last hour, where I think we're down to 115, 120. That's pretty good retention. I don't know about you, but at live meetings that are this long, I mean, the crowd's thin near the end. So I want to say thanks to you all that have remained with us. And for those that cut out, we'll make sure that LA Care and IEHP don't allow them to participate in this program. I'm just kidding. We're not going to do that. What I really want to do is wrap this all up before 5 o'clock. And to the sponsors, let me be very clear about this. I did not, and I should have recognized Dr. Tony Kuo and LA County Department of Public Health and the CDC 1870 Wellness Program as a key financial sponsor for the work we do in LA. And what's important is that that funding supports work that naturally sort of includes IEHP. So they are a critical part of this collaborative, also in very many ways tied to the similar grant that Jessica Nunez de Ibarra has. So a lot of good sponsorship for this work moving forward. To the presenters, I have been hearing all day long how wonderful everybody has felt about the speakers, everyone from the beginning, our keynotes, to the teams, to our guests, to our breakouts, and then the participants. Our health plans, we've already have said enough about them and their commitment to this work. The health systems that have participated. We have Kaisers, we have VAs, we have Sutter, we have so many different organizations with us. The pharmacies, both the pilots and the pharmacies that are interested in this program, and the schools of pharmacy, the ones that are currently engaged, the ones that are here today to learn more about it. The staff that have made this work, I just have to say thank you for just a day of, I think a day that worked out very well. Nobody fell asleep. Everybody was active and engaged and shared, and it seemed to work and get the message across towards our purpose, which we had outlined at the beginning of the day. Quick recap. You heard a keynote, and hopefully for those of you that have not met Dennis Wagner, very inspirational and I think a very focused presentation on leading, choosing to lead, making it a personal decision. I hope all of you take that to heart and understand that this man who went to school with 12 people in this entire school ended up leading quality improvement and innovation for CMS because he chose to lead. And he gave you so many examples of how that works. The chronic disease control branch of CDPH told you how much this work aligns with CMM, how supportive they are of it. They are after gaining HIE access. Again, I had a conversation with Jessica Nunes de Ibarra. She said, look, if you could ask for one thing, what would it be today? And I said, this is it. We need HIE access. We need to be able to get info real time and share it real time. As I think I mentioned before, she is very actively engaged with the California Medical Association, with medical leaders and healthcare in the state, and removing those barriers to CMM spread. You heard Dr. Tony Kuo, really a master of what he does, talk about the resources that are available to help us reach our goals. And again, all the support he's given us financially through the grant. The journey, I thought that worked remarkably well. The comments that you guys shared in the chat confirmed the excitement of having LA Care and IEHP share. I think I could see Mike Blatt in my picture. I want to acknowledge him and the incredible work that he does and moving things forward at lightning pace. Really, things couldn't happen without him and his team. You heard they're all in. They're all in. They believe that this is important work. This is part of their mission. They're giving support. They see it as a key pop health strategy. Alex yelled for. He said, hey, this is last call. We don't get this right. We don't get on board. There may not be another chance. But he's saying that because he believes that their approach of CRMC is the approach that works for health plans. And that's really important. We're trying to create a best practice model that other plans can learn from, can adapt. And I think we're well on the way in that direction. And then the fact that, as you learned from EdgeI, this amazing pop health direction that IEHP is headed towards is very much about the work of CRMC and CMM, including technology and other tools to make pharmacists more effective. The teams did just such an amazing job sharing their journeys, talking about the fact that, first of all, CRMC works, how it works. They talked about the value of the health plans, the training, the process, the coaching, the consults, and the payment. The payment is something that works for them in terms of the ease of the process as well as the amount. And I didn't know what to say about Crystal, your patient. Just wow, right? I think there were more comments about your patient than anything else that was said today. Really a great job working with that patient and having her articulate the value of you and your program and of CMM within CRMC. We heard about preparing for a community-based pharmacy CMM for those teams that are not currently part of the pilot. You saw an example of initiating a CMM workflow and then an advanced team continuing to advance CMM workflow. I thought that provided really nice perspective, and both are really excited about the work they do. Some tips on CPAs and some great ideas on personal branding. And we already heard some comments about how that advice will be operationalized moving forward. And then I think that some of the best people in homeless care were able to share some insights on working with homeless patients. You heard about trust, engagement, education. I would add, don't underestimate what homeless patients can do. To be honest, I think they were better than many of my Beverly Hills patients in terms of following directions and being very adherent to doing the right things, because they don't go and look for other advice once they trust you. They trust you, they listen to you, and they follow through. Keys are meeting patients where they're at, work with their needs, be flexible. And I love that Dr. Gregerson said that pharmacists by nature have the compassion, have the skills that deliver critical needs to homeless patients. Something that's absolutely true. And then for the breakouts, in our CMM pilots, we talked about optimal ways to deliver follow-up care, engaging all the different stakeholders, family and caregivers, other members of the healthcare team, community health workers, social workers, being adaptable and available, changing up hours of availability, checking in frequently with patients, virtual visits, getting easy access to you, using the patient engagement tools. Nader pointed out that at our last learning session, we had Dr. Dree Wang sharing motivation interviewing. He said he still refers to those notes. That tells me we're going to bring her back for the next learning session to advance those skills. and then tools to improve adherence, self-monitoring. Just a great discussion that we had. So I want to thank Nader for that. And I know what Jessica and Bianca shared because I've heard it before. You just wrapped up a very rich conversation about cultural competency and patient self-management. So that was our day. That was our day. And what I'm asking from all of you are a couple of questions. What are some key insights that you'll bring back to your organization from this meeting, kind of borrowing from the purpose of our meeting that I said earlier? And then most importantly, let's go back to what Dennis said. What requests do you have? What offers can you make? And what actions will you commit to? Right. Actually, being 4:41, can we do a breakout here? Is that possible? Anybody can administer that? I think it's worth having a little bit of time, maybe at least 5 minutes to convene, talk about these things, come back, share some of these commitments.
Yes, totally possible.
Okay, why don't we do that? 5 minutes, quick discussion, come back to the room.
And while we prepare that, if there's anything, Diane or anyone, any housekeeping?
We'll get to the housekeeping after, but we'll wrap up this part and then we'll do the housekeeping.
Only because Mariel's working on it right now.
Oh,
it might take just a minute.
Oh, okay. Yeah, I'm sorry. I did not give anyone notice. That was my.
So
my
in
bad.
terms of the CPD portfolio, just to let you know, some people asked me, like, do I email it to you? Where do I turn it in? This is a living document that's intended for you to be ongoing beyond today. So I just encourage you to keep that close, see where that can take you. And we'd love to hear from you how that has impacted your thoughts and your work.
Also with the great presentation material, oh, sorry, as soon as that happened, breakout room.
Okay,
well,
see.
to be
I'll make
continued.
Okay, insights, requests, offers, commitments. Let's go. What I really love about this group is they like to talk, and boy, 5 minutes goes fast. So thank you all for engaging. The first question is probably the most important, is because that naturally leads to the commitments to action. So who would like to share some of the insights, the key insights that were picked up from this meeting? We have several, but I'd like to hear what else is out there. You can throw in the chat too, but I would love to hear some verbalized.
Dr. Chen. Hi, this is Ramesh. How are you?
Yes, sir. Go ahead.
I think we need to kind of start doing more for the homeless in the area where we are at. We already see the regular population. We do our best to kind of help them out. I think we need to step out of our comfort zone if we're going to help the people who need us most.
Yes, that's great. Keith Fujinaga echoed the same comments. He's in an area where there's quite a bit of homelessness, and he said he gained quite a few insights. So thank you for sharing that. Fantastic.
Steve, this is Neil.
Neil, go ahead.
I agree with Ram, but I think today we have to really work ourselves into combating the health inequities. And it doesn't just go for the homeless, it goes all the way across the spectrum. So if we can do our part as pharmacists to diminish the inequities, I think that's really a key thing. And it'll probably get us a lot more, it might get us a little bit more backing. Working in that direction right now.
And I think that's so true. We are the equalizers. Having worked at Beverly Hills and Skid Row, I can tell you that pharmacy is the equalizers in health disparities, without question. The problems they have in Beverly Hills are the same in many ways when it comes to medication therapy. So very well said.
Hi, Steve.
Steve.
Oh, is that Marilyn?
It is.
Oh, go ahead, please.
Hi, Steve. And Neil, I can't echo what you said enough. And I think that the reason pharmacies are the ideal place to spread CMM is because of their access and our lack of access to healthcare for so many populations. And my ask and also my commitment is that this really needs to happen throughout the state. And I want to commit to helping to pull it up the state further. As well as I think the key component is really to work with our Medi-Cal providers, and especially in this new era of Medi-Cal RX and the idea that we can push things into the medical benefit, since the pharmacy benefit is a different place now, and really take the examples of LA Care and IEHP and spread them throughout and get these vulnerable populations who aren't getting access to care cared for.
Thank you. That's so well said. Thank you so much. We will take you up on that offer. That's a great offer. I love that action. Thank you.
Hi, Steve. Can I make a quick comment?
Of course, please.
Okay. This is specifically for homeless people. Okay. I wanted to give an example of what we did with C4P program. We were working with about 41 clinics. And one of the clinics that we work with have a lot of homeless.
Unfortunately, your audio is
I
not
think,
really,
yeah, you're cutting in and out. I'm sorry.
So if you want to chat in your question, that might be better, because right now we're having a difficult time listening to what
can't hear it all. Yeah.
what you're saying.
Okay, let me put it.
Thank you. Sorry about that.
Okay, that's okay.
So yeah, I think we have another question to answer, that sort of the next two. I asked you for requests, which and offers, which Marilyn just gave, and action commitments. And then one more. What can you do by next Tuesday? Gee, that's 2 days from now. Next Tuesday to begin advancing, optimizing med therapy for your most vulnerable high-risk patients. And I don't expect you to completely transform what you do in 2 days, but what's the first step you can take? Who do you need to talk to? Who do you have to convene? Who do you need to reach out to? That's what I mean by next Tuesday. So let's answer some action questions. Requests, offers, action commitments next Tuesday. Who'd like to share something?
Steve, next Tuesday, this is Marilyn again.
Yes.
I will be training our half and the other half on Thursday of our first year PharmD students on how to do Medicare Part D outreach to vulnerable populations. And within that is the whole idea that it's a whole patient. It is an entire med list, and the whole idea of cultural sensitivity, humility, and how do we engage these people in their care and connect them in their communities.
It's fantastic. I love it. Very good. Any others? How about, I'm going to call on someone. Is Dr. Lisa Goldstone on the line?
I am, Steve.
Okay. Any chance you have an offer for this group?
I do, and it actually fits in so nicely because I've been listening to the discussion talking about patients who are homeless, health inequities, vulnerable populations. And so I would like to talk about a new collaborative that we're putting together. So if we advance to the next slide. So our new collaborative is Psychiatry for Population Health Pharmacists. And so I think as healthcare providers, we're all very aware of just the great mental health needs right now in our population. And I would say that those needs have really escalated lately because of COVID-19. And we're all familiar that a lot of times mild to moderate mental health conditions are really treated in the primary care settings and other outpatient settings that are not psychiatry specific. And ideally, you'd really want a board certified psychiatric pharmacist as part of your team in all of those settings. But as a board certified psychiatric pharmacist myself, I'll tell you, we don't have enough of us. There's only probably about a little over 1,200 of us across the entire nation. So, you know, we don't have enough bandwidth as BCPPs to serve both psychiatric and primary care settings. However, because we know that non-BCPP pharmacists in primary care and other outpatient settings are able to provide services that produce these really great outcomes and really improve access to care and patient outcomes, our thoughts are that these pharmacists with adequate training can really help fill this gap in care and also be able to assist with referring these patients to BCPPs and other psychiatric providers as needed. So we'll go to the next slide. So what our goal for our collaborative is to really increase access to patients with mental health conditions. And these patients fall in some of the populations you're all talking about. Our patients who are homeless, our patients who have other health inequities. Definitely patients with mental health conditions are a very vulnerable population. And so our goal is really to equip the non-BCPP pharmacists in these settings with the skills that are really needed for them to be able to provide medication management for some of those low complexity psychiatric disorders. So persons who have mild to moderate depressive disorders, anxiety disorders, insomnia, substance use disorders, and also be able to know how to and when to refer the patients who have mental health conditions who really do need that psychiatric specialist level of care. So like our patients with serious mental illness, so schizophrenia, bipolar disorder, treatment-resistant psychiatric conditions. And what we want to do is really make sure what we're doing is aligned to whole person care and also population health goals. So we're anticipating to launch this collaborative in 2021 in the spring. And I put my email because if you are interested and you would like to participate either in our focus groups that we'll be having this fall, early winter, to really hear from all of you about what your needs are, or if you would like to be possibly one of the sites or incorporate this into your sites, I'd really love to hear from you because it sounds like this group has a lot of good energy and is really excited and wants to help the populations that myself as a psychiatric pharmacist wants to do as well.
Thank you so much, Lisa. You and I have talked about this, and such a critical element in caring for all primary care patients, but particularly for the underserved and the targets that patients that we're targeting. Pauline Chen from DHCS, she has her hand raised. Pauline, do you want to say something?
Yes. Thank you so much, Steve, for inviting me to join this today. And I think this is a phenomenal and fabulous workshop. I am speaking not representing DHCS and Medi-Cal, although I work at Medi-Cal, but I wanted to, I'm really empowered by also Steve, you, and many others today, that I wanted to say that out loud, that I support and will do everything I can to help push forward, because I think it's so much needed for medical population, especially, but it's all good for all California. I have been reassigned to help support Governor Newsom's COVID-19 as a case investigator and contact tracing. And through that, I learned so much about cultural humility as well, and really the need for chronic conditions for those at risk for COVID-19. I talk to them on a daily basis, and I truly know that the coexisting comorbidity really is a difference between a life and death. So it's really, really important that we move forward. And I know that there is so much need out there. And thank you so much, Steve, and thanks everybody for all your fabulous, powerful message today.
Well, Pauline, thank you so much for sharing that. Pauline and I had a long conversation, I think about a month or two ago, and boy, I have the greatest respect for this leader in our state. We're so lucky to have her in DHCS, representing the needs of patients and also advocating for pharmacy and the role that we can fulfill. So thank you so much for sharing that. I'd like to have just one more commitment, right? We heard Marilyn give us some great ideas. How about, I hope you don't hate me for this, Vivi. Vivi, are you still on? I think I saw your name somewhere. Could you possibly share some of your thoughts on what you heard today? Vivi Vo from Blue Shield of California. Yeah, she hates me because I called on her. Let's see. Yeah. I don't know. Oh, here you are.
I was definitely muted. Yes, you caught me off guard there.
I'm sorry. I should have texted you or something. But would you, if you have any insights or things that you'd like to share as somebody who is a payer in California, I think this is the first time you've been in one of our learning sessions too.
Yes, that's true. Thank you for the opportunity. It's very great insights. No, I'm very surprised of how many of that is in the community are very interested in providing CMM for members and really advance our profession. And, you know, with me being with Blue Shield, I was not aware that there's other health plans out there that doing similar work as we. I mean, I heard a little bit from Medicaid and Medi-Cal, but, you know, and I heard about what Edward Chai talked about his plan. And it's great that you know, we have leaders out there who's really advocating our profession, and hopefully one of these days, all members will be eligible for CMM work, and our pharmacists will get incentive payment or reimbursement for their services. So this is really an eye-opener for me.
Great,
Steve,
great.
so thank you.
Thank you. And look, you come up from a plan that is also very innovative and very much reaches out to pharmacists for solutions. So I want to thank you and Blue Shield and your team, Selena, for leading that charge. And there's an open offer here. If you would like to collaborate with us, we'd be happy to do that. Okay.
Yeah, no, definitely. And we always looking for more advanced practice pharmacists to join our network. So please ping me or email me separately, and we can talk further.
Great. Thanks. I did see your message, so thanks for sending that out. Okay, so we are going to wrap up here with at least let you know what's coming up. So there are some, you saw our chart before, showed a lot of completed and ongoing. Now you see ongoing and pending, right? So we are transitioning our weekly meetings to a little bit less often. We're going to offer our clinical pharmacy technician training course to our members in our collaborative. We're going to continue to match up pharmacies with FQHCs and clinics. We'll start a refresher for IEHP now that they're launching their asthma focus coming up. We're going to distribute the completed CRMC practice alignment guide and work on refining the CQI process that goes on with the dashboard. So a lot of things still coming up that we need to do before the next learning session in spring of 2021. So I think Diane has a few things to conclude. Diane, I think you're going to talk about next convenings and CE details. Okay.
Let me just share again my screen.
Do you need me to get out? Okay, go ahead.
So I know we're running a little bit over, but I'll only spend a couple of minutes with announcements and a couple of reminders, since I know it's been long, but it's a really valuable day. So first, thank you for attending today's learning session. We are already going to start planning for the next one. Right now, it's tentatively scheduled for April 2021. So we want you to say the date. The exact date is yet to be determined, but we will, as soon as we have that information, we will make sure to notify you. For CE,
sorry, quick note, Diane. We're trying to make that in conjunction with the CPHA Western Pharmacy Exchange meeting. So it'll be right around that time.
Okay. So regarding continuing education, you will be receiving an email most likely tomorrow. First, attendance has to be verified for the various workshops throughout the day. So when you break it out, there are about 5 separate workshops, different topics that were covered. And so you will receive the links to submit the required materials in order to obtain CE credit. And then lastly, I know we briefly mentioned it, but we are really encouraging all the participants from today to fill out the LA County Department of Health survey. We're partnering with them to administer the survey. You will probably also receive a follow-up email, or you will sometime this week from them directly to encourage you to fill it out if you haven't already done so. It's a really important survey that they want filled out. They really want to make sure that they have the data of current pharmacy profiles. So it would be, you would really help us out if you would also fill that out when you have the chance this week.
Yeah, and to be clear, they are sponsoring this through the 1817 CDC Wellness Grant. So really, it would be so important for you to do that for us. So thank you for that.
And I think it's a relatively quick survey. I don't think it's too long.
Yes, exactly. Okay, so with that, while everybody else is going to say this, that we'll never go back to 2020, I think we're going to look at 2020 as a year where we start turning the corner on developing value-based programs that offer CMM to patients in need. So thank you all again for your attendance today, for your contributions, and we look forward to seeing you at the next learning session, or in the case of our teams, next week. Thanks so much. Have a great night, everybody.
Everyone.
Bye, everyone.
Great. Thank you.
Thank you, everyone.
Bye, everyone.
Thank you.
Bye, everyone.